Good afternoon, and welcome to this bill hearing for the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel, and we do have a few virtual witnesses today, so please be patient as we switch back and forth. Please note that food and beverages are not permitted in the gallery. You will see delegates have drinks at their desks because our meetings can run quite long and we want to make sure everyone stays hydrated. Please make sure to turn off your phones at this time or turn them to silent. And if you see that we have members that are not present, understand that they're in other committees on other bills, testifying for other bills, but they are staying informed on our proceedings. And please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please keep your questions shorter than the answers. Just a reminder that our sponsors are not time limited, but witnesses are limited to 2 minutes. And we are going to go in this order today. House Bill 1563, followed by 1055, 1119, 1042, 1087, 1047, 1136, 1150, 1092, 1114, 1143, 1135, 1021, of course, pending the availability of our sponsors. And I want to reiterate that our list is 2 pages long as you are considering your best questions. With that, we're going to start with House Bill 1563. This is Emergency Room Services and Post-Acute Care Coverage and Facility Studies. Welcome back, Madam Speaker, to our committee. If you would like to approach the table and bring your panel, and you can get started with your testimony when you're ready.
This is my last bill for the session. I did not keep many. I gave a lot of them away. And I'm glad I did because they were in great hands, and it's great to be here. I have to say that I'm sitting here the other day, I realized how much I miss you guys, honest to God, I do. This is, you know, we are a home, a family. This was our home, and just sitting there, I have like a sadness, but it's not that I'm unhappy in my current position, but I just miss you guys a lot, and I hope that we stay together because we invested so much. This is a beautiful committee, and we said on the floor today, you're not supposed to have favorites, but you guys, I love you dearly. So good afternoon, Madam Chair, and thank you. Good afternoon, Madam Chair, and members of the committee. Thank you for the opportunity to present to you House Bill 1563. And you probably are wondering why are we putting this bill in? As this committee is very well aware, Maryland's emergency room wait times are among the longest in the country. In 2024, the General Assembly enacted legislation to establish the Maryland Emergency Department Wait Time Reduction Commission to address factors throughout the healthcare system that contribute to the increased emergency department wait times. The commission submitted an annual report to you in November 2025. Among the report's key findings is a significant impact of post-acute care shortages in both the long-term care hospital and skilled nursing facilities and delaying discharges. That is one of the bottlenecks. The report also found that data fragmentation across acute, post-acute, and community setting hampers system coordination and policy design. No coordination, communication, no one waiting at the other side to take that patient. 2 of the Wait Time Reduction Commission's selected priorities are standardized bed capacity and occupancy metrics and improving post-acute access. House Bill 1563 addresses these. And it first addresses the standardization of metrics by requiring the Maryland Healthcare Commission, sorry, but you are going to have to continue to do work, and the Health Service Cost Review Commission to conduct a study to quantify the state's bed capacity in post-acute care settings and in hospitals, and make recommendations for a collection and auditing process through which hospitals and post-acute beds are reported to both of these commissions every day. The bill addresses access to post-acute services by requiring the MHCC and the HSCRC to conduct a study analyzing options to facilitate clinically appropriate transitions from acute to post-acute care settings. I know you're thinking more studies, but we do, because we don't know what the bed capacity is or the type of beds that are out there. And it is important to do that. The findings of both studies are due to the Senate Finance Committee and this committee by July 1st, 2027. So it's not a long time, it's next session, God willing, and we'll be able to implement some of these recommendations. Access to post-acute services is also addressed in this bill by requiring insurance carriers to include in the Maryland Insurance Administration Annual Appeal and Grievances Summary Report data on adverse decisions related to admissions to skilled nursing facilities and inpatient rehabilitation facilities. So if those facilities are denying, guess what? The hospitals cannot move that patient, all right? And that is happening. And we need to know to what extent is it happening, and it needs to be reported to the MIA. Finally, the bill addresses the impact, and I know some of you are not going to want this because it's a mandate, but the bill, what it does is that, let me take a step back. When you go to the ER, you go to the ER because you feel sick, right? Because you think that something's really wrong, and that is where you go. And a lot of times that happens on a Friday night and Saturday and Sunday night as well. The person, the nurse who has that patient in front of them, as they're doing an assessment, cannot really tell whether it's really an emergency or not, right? And they have to take care of that patient in good faith and not say, well, get out of here. You don't have an emergency, right? Because they don't know. It's also a liability. So this bill, it actually has a mandate that, when it comes, it says the bill addresses the impact of insurance denials on emergency room utilization by prohibiting an individual group or blanket policy or contract issuing the state by an insurer, a nonprofit health service plan, or a health maintenance organization from denying a covered emergency room service solely on the basis that the insurer or enrollee did not experience an emergency medical condition. So you have these denials. So I am aware that the League of Life and Health Insurers of Maryland is opposed to this provision of the bill. And yes, we met with them before, but I look forward to working with them to reach consensus and clarifying that insurance coverage of emergency room services is going to be covered. They actually would like the layman, it's in the Kaiser letter. It says here, the House Bill 1563, it says contains a provision that prohibits a carrier from denying coverage for emergency services solely because a patient's condition was not ultimately determined to be an emergency. And it says this essentially overrides the longstanding prudent layperson standard. So basically, they want us to codify that, which is what we have now, but it is not working. So I asked the Maryland Insurance Administration, and I asked Aaron, poor Aaron, who's here to take all your hard questions, to meet with the insurance carriers and try to come to an agreement where maybe we'll codify it, but there has to be some, what is it they call it, carrot and stick, something that we can hold, some teeth in it, so that we can hold them accountable, because they're denying it right now. Imagine if you're that person that goes to the ER and you went in there with some chest pain, and they decided what you have is indigestion, right? Not anything related to a cardiovascular disease, and then you get stuck with that bill. So we have to be able to find some type of compromise, some type of middle ground here. So I asked the committee to please return a favorable. We're almost there, and you hear the testimony, and I am really confident that we're going to get there and have to you a product that you'll be able to be proud of and that your constituents will appreciate. Who would like to be next?
I think I'm up. Thank you. Good afternoon, Madam Chair and members of the committee. Thank you, Madam Speaker. For the record, I am John Crom. I'm the Executive Director of the Health Services Cost Review Commission. Thank you for the opportunity to speak today in strong support of House Bill 1563. Emergency department length of stay is recognized as a long-standing challenge for Maryland hospitals. We discussed this in a briefing earlier in this session. As I mentioned, then it is a complex problem with multiple contributing factors, and as such, really requires multiple solutions. So the state has made significant efforts over the last couple of years to address many of the underlying causes of extended ED stays, such as expanding access to crisis support services, strengthening care coordination. The HSCRC has worked in close collaboration with hospitals and other stakeholders to ensure, in particular, that hospital costs associated with treating flu and other respiratory cases, the most significant causes of emergency department volume increases, are covered, right? We're identifying and sharing ED best practices. We're examining factors impacting hospital throughput, and particularly zooming in on factors that increase lengths of stay, hospital lengths of stay, for patients who will eventually be discharged to post-acute care facilities. They tend to stay much longer in the hospital than in other states, about 20% longer. So that is a major driver, you can imagine, right? It creates the backlog, right, in the hospital that stretches into the ED. So those efforts are beginning to bear fruit, but work remains to be done, and a couple of the key areas that are going to be needed to drive further improvement are addressed in this bill. As Madam Speaker noted, thank you, this bill will cover a couple critical areas around bed capacity and post-acute care strategies. We stand in strong support and happy to answer any questions.
Thank you, Madam Chair, committee members, Marie Grant, Maryland Insurance Commissioner, here in strong support on behalf of the Insurance Administration of House Bill 1563. I want to talk about the two insurance provisions in the bill that the speaker discussed. First of all, there's a provision in here that would prohibit our insurers from denying solely based on the medical, the fact that a person didn't experience a medical condition. I want to talk a little bit about the data that we're seeing about denials for medical necessity in the ER in our risk market. I think as this committee is well aware, we have annual reporting on adverse decisions. That's denials based on medical necessity. So not denials based on fraud or any number of other reasons, solely for medical necessity. And we saw a jump in the early 2020s that is still higher than where we were in 2020 with denials based on medical necessity, despite pretty strong law on the books that when folks are experiencing an emergency medical condition, they should be able to go in and get seen, right? The hospitals are obligated to provide that care. Denying based on medical necessity should be few and far between. But in 2023 in Maryland, we saw 199 of these denials. In 2024, we saw 61, 2/3 of which were from one insurer. So I think we look forward to working with the insurers to figure out this language, but we do think there is an issue here that we need to resolve to make sure there's not inappropriate denials in this space. The second insurance relay provision has to do with our reporting of adverse decisions. We do report out right now on adverse decisions related to skilled nursing and rehabilitation, but this bill charges us with looking at that more holistically so we can understand better denials relating to post-acute. That will in turn help us understand the bottlenecks that are happening in this space that may be leading to longer ED wait times. So with that, happy to answer any questions at the appropriate time.
Absolutely. Thank you so much, Madam Chair, members of the committee. For the record, my name is Andrew Nicholas, representing the Maryland Hospital Association, here in strong support of House Bill 1563. I want to thank the Speaker very much for introducing this bill. As was described, it gets to some key issues that hospitals are experiencing that are directly impacting care delivery. It does speak to the specific issue of the denials that we're experiencing in our emergency departments, where claims are being denied when a patient is determined not to have an emergency symptom. In fact, as was just alluded to, what we're seeing is 45% of our ED denials are now for medical necessity. And that's very challenging in the emergency department environment where hospitals are required under EMTALA to treat and assess every patient as they present. And so getting at that practice is very important, and we want to thank you. You're going to hear more about that from a bill sponsored by Delegate Gazzone tomorrow that gets maybe a little bit more granular into that issue. And then secondly, the bill speaks to the challenges that hospitals are experiencing when discharging patients to post-acute settings. I'm privileged to serve on the Emergency Department Wait Time Reduction Commission. I'm not here testifying in that capacity, but this has been an issue identified by the commission as really contributing to the long ED wait times. In fact, hospitals' average length of stay for inpatients who are discharged to home is actually on par with most of the nation, but we see the significant delays when being discharged to a post-acute care service line. So I think getting at the issue of either reducing prior authorization delays or addressing access and time of transfer issues for that discharge to post-acute care services is critically important. And we think these efforts will help reduce those ED wait times that are currently being experienced in Maryland hospitals. So with that, we urge a favorable report on the bill and happy to answer any questions.
You're next.
Well, good afternoon, esteemed committee. I'm Calvin Ball, Howard County Executive. It's an honor to be here in strong support of HB 1563. I want to begin by recognizing the Speaker for her leadership in advancing this timely and important legislation. This bill protects Maryland families from retrospective denial of emergency room claims based solely on a final determination that a condition did not meet the federal definition of an emergency medical condition. When someone experiences chest pain, shortness of breath, or acute symptoms, they should not have to weigh the financial risk against their health. Aligning coverage protections with the prudent layperson standard promotes fairness, predictability, and confidence in making pressing healthcare decisions. In Howard County, we are served by one single hospital, Johns Hopkins Howard County Medical Center, and that reality makes system capacity and patient flow especially critical. When our emergency department is strained or post-acute placement is delayed, there are limited options to redirect or redistribute patients. For that reason, we have made substantial local investments, $15 million toward construction of a 29-bed observation unit to reduce emergency room wait times, partnering with the Maryland Hospital Association to develop discharge suite and accelerate inpatient discharges, tripling psychiatric bed capacity, investing $3 million toward our state's shock trauma, and we continue to fund mobile integrated health initiatives. The studies required in HB 1563 will further support these efforts, directing our Maryland Healthcare Commission and Health Services Cost Review Commission to examine the hospital and post-acute bed capacity. This data will allow counties just like Howard County and all of the counties in which you serve to better better focus resources and deliver measurable results. This bill aligns with our growing needs, and respectfully, I urge a favorable report. Thank you.
Good afternoon, Chair, members of the committee. My name is Doug Jacobs, and I'm the Executive Director of the Maryland Healthcare Commission and a practicing primary care doctor. I'm here in support of House Bill 1563. MHCC has had a long-standing experience studying hospital bed capacity and post-acute care infrastructure in Maryland. Through our health planning functions, we regularly assess inpatient capacities, utilization trends, and the availability of services across the care continuum. Extended emergency department length of stay has been a persistent challenge in Maryland, as has been described, and these pressures are not new. As you heard from Dr. Crom, discharge from hospitals to post-acute care settings is oftentimes very challenging. And hospitals report that patients who are clinically ready to leave remain in inpatient beds because of delays in securing appropriate post-acute care placements. This creates bottlenecks in high acuity, high cost settings and contributes directly to ED length of stay. These dynamics underscore the need for a coordinated, data-driven approach, and the bill requires MHCC, in collaboration with the HSCRC, to conduct these two studies that have been described. And it builds on the Emergency Department Wait Times Commission to strengthen the state's data infrastructure to improve our ability to assess capacity across all care settings. We are ready and well-equipped to do this work. The bill helps all of us ensure that patients are getting the right care at the right time in the right setting. Inpatient care that's available when it's needed, and the tools to safely bring patients and their families to their post-acute care settings when it's appropriate. For these reasons, the Maryland Healthcare Commission respectfully requests a favorable report on House Bill 1563. Thank you, and happy to answer any questions.
Thank you very much for your testimony. I'm going to open it up for questions from the members. Delegate Kaufman.
Yes, this question is for not delegate, Mr. Nicholas. I promoted you, I guess.
He may not see that as a promotion.
Well, serving under you, Madam Speaker, I'm sure he would.
Oh,
Absolutely, be an honor.
But my question is, when a Tom, Dick, or Harry comes into the emergency room and they are denied coverage because allegedly they didn't meet an emergency medical definition, what happens then? Does the person now have a bill of thousands of dollars that they need to fund that they may not have the money for and go into medical debt? Or do you eat the cost, or some combination thereof? Or what happens next? What are the real world consequences of the denial?
I think that's a great question, Delegate, and the answer, I think it depends. It kind of depends on the individual circumstances and the nature of the denial. The first stage would be, pushing back on the denial and asking for a reconsideration. So the denials actually that get captured at the higher levels, say by the MIA, are only those that go all the way up to that point. And oftentimes hospitals are simply agreeing to a lesser charge to move the case forward and will just accept lower payment than really what is adequate to cover the cost of the services. Sometimes the cost is borne by the patient, 100%,
Yeah.
or the patient may qualify for financial support or enrollment in a public program like Medicaid.
Okay. Thank you. Can I have a quick follow-up? Yes, my question is, what percentage of, whoever's best to answer, what percentage of denials are overturned on appeals, since Mr. Nicholas said his association spends a lot of time appealing denials?
I don't have the data on ER services with me specifically, Delegate Kaufman, but I did see that in 2024, about half of the adverse decisions resulted in a grievance that's a further appeal along the line. And once those, so there's the base of denials for medical necessity. Those don't always get appealed because sometimes folks just don't want to go through the time and effort to do that. but there's an internal grievance with the insurance company where sometimes the insurance company will overturn itself. And then if it makes it all the way to us to take a look at with our independent medical experts, we have a very high rate of success in overturning those cases. But I don't know that apples to apples I think you're looking for, and we can see if we could get that for you.
If you could get it for me
Yeah.
in the committee, that'd be great. Thank you,
Yeah.
Madam Chair.
Delegate Gazzoni.
Thank you, Madam Chair. I believe that it was Dr. Crum who mentioned this, and I just wanted to confirm. I think you noted that we're about 20% higher in terms of the essentially getting people out of hospital beds and into post-acute care
Yeah.
than the rest of the nation. Is that what I heard correctly? So keep going. Go ahead.
Yes, Delegate. So to clarify that statement, so of the patients who will be discharged, so their disposition is going to be discharged to post-acute, when we look at their inpatient length of stay, right, so this is the number of days that they're spending in the hospital, their observed stay over the expected stay that you would expect if there was a similar, kind of patient on average, right, is about 1.2, right, statewide. Different hospitals, the number is a little bit higher, a little bit lower, but statewide average, it is significantly higher and looks to be significantly higher than discharges to other settings like the home.
Okay. Can I have a follow-up? Thank you. So just making sure I'm putting the dots together correctly. This means that currently, given all the other things we've done around ED wait times, this is sort of the top hole in the tent at this point, or one of the top holes of the tent.
There are many tent poles.
Yes, I'm sure.
But this is certainly one of the biggest impact problems that we need to solve.
Great, thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you, Madam Speaker, and your panel. I guess this question is for Dr. Jacobs. I love the musical chairs.
Musical chairs here.
We're talking about this prudent lay person standard, and the opposition will come up later. As a physician, is your experience that when patients show up in the ER with a symptom that is later deemed to have not been significant enough to have warranted, that they would prefer to wait for 6 or 7 hours, and that's why they didn't go to urgent care or use the nurse line? Or is there some other reason that they show up with these symptoms to the emergency room if there was someplace else to go?
Thanks so much for the question. From a clinical perspective, I'm a primary care doctor, and I see patients, and oftentimes, as was described by the speaker, it is often true. Someone comes in with chest pain, and it's hard to decipher. Is it a cardiovascular event? Is it gastroesophageal reflux disease? The patient gets sent to the emergency room, and oftentimes there is that uncertainty that when a patient is going, oftentimes some people are rightly concerned. They've heard they have an aunt and uncle that just had a heart attack. They go to the emergency department because they're having chest pain, and it's great when they get ruled out. They're not having a heart attack, but we oftentimes don't know that ahead of time.
Okay, may I have a follow-up? Thank you. And on a slightly different direction, in your opinion, what role, if any, in telling the prudent layperson to go to the ER has the tendency of the last 20 years for answering service on almost every doctor's line saying, if this is an actual emergency, please hang up and call 911. Does that have any role in the fact that so many people are showing up in emergency rooms and later having their services denied?
I haven't seen data specifically on that piece of it in terms of answering services, but just confirming that oftentimes physician answering services do have, as you described, that message there.
So we're training them.
Yeah.
Thank you. And then we're blaming them and making them pay for it. Thank you. Thank you, Madam.
Seeing no further questions, I just wanted to give you an opportunity to respond, because I know you're still working through some amendments and discussions. There was proposed amendments from Lifespan Network and from the American College of Emergency Physicians, and I didn't know if you had seen them and if you wanted to address them And I think I also heard that you were looking at potentially codifying the prudent layperson standard.
Yeah, the lifespan one, we are okay with it. The emergency room physicians, we're not.
Okay, perfect, thank you.
You're welcome.
And I think I heard you say that you're looking to codify the prudent layperson standard, which I learn something new every day in this. We were the first state to adopt it.
Yes, so we are open to working with them and codifying it, but there has to be some teeth to it as well. Because right now, they're still denying it, and that is supposed to be the standard, right? So if we're going to codify it into law, you're going to follow the law. But if you don't follow the law, then there must be some teeth there. Because all the resources that the MIA is spending, right, when the question was asked by Delegate Kaufman regarding what percentage of the cases that are appealed are you able to overturn, they're able to overturn more than half of them, but it's a lot of calls and a lot of resources spent to do that when that should not happen.
And when that standard is the standard in Maryland and 47.
That's correct.
So we hear you. So we're working on how to get there, but also make sure that that it has teeth.
Thank you.
Seeing no further questions, this concludes this panel. Thank you very much.
Thank you so much for having me.
It is always a pleasure to have you in our committee.
And you guys can
you're
come
home
and
away
visit
from
me.
home.
You're kind of lonely all the way over there.
We do have an unfavorable panel. I have Allison Taylor, Tina Quigley, and Sarah Case Heron. If you want to come to the table, and you can begin your testimony when you're ready.
All right. Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. It is pure drudgery to oppose the panel that just went before me, so here we are. But anyway, I'll say I do totally agree with them on everything they've said about post-acute. In fact, my sweet little niece has been in the hospital for a month, and it took her 4 days when she was ready to find a place for her in post-acute. So just one data point there. Speaking to the prudent layperson standard, what this is health insurers are required to cover an emergency service if, like, a reasonable layperson would think that the symptoms they've arrived with are an emergency. I think where the difference is, if it turns out not to be an emergency, federal law does not require coverage of that. So our read of the bill was that this was going against that. Maybe that's not everybody's interpretation, so we look forward to the further conversation. I'll say to Delegate Hill's point, you know, if someone calls on the phone and they get that message, if you think it's an emergency, call 911. That seems like it should fit under this. I did speak to Ms. Hopwood, too, about a fact pattern. She lives in Chestertown. There certainly are times when urgent care is not open, and I did confer with Kaiser, and that's not a scenario where they would deny a claim. I will also say Kaiser is not the one insurer that the commissioner mentioned. So anyway, I think we can work this out, and I'll stop there.
Good afternoon, Chair Bagnall, members of the Health Committee. My name is Sarah Case Heron, and I'm here representing the League of Life and Health Insurers of Maryland. As my colleague from Kaiser Permanente mentioned, it is not particularly fun to be in this seat opposing the Speaker's bill, but we do respectfully oppose as currently drafted. As Allison mentioned, our concern really does center on the prudent layperson standard and the changing of the standard, which, Chair, you accurately noted, started here in Maryland and has been a cornerstone of emergency medical treatment since. While, again, it's not clear that the intent of this bill is to abandon this established standard. It's also not clear from the bill's language that it doesn't deviate, which is why we are standing up here today. We are very sympathetic to the sponsor's intent. However, our worry echoes the flag from DBM in the fiscal and policy note that mandating coverage regardless of severity of the condition may inadvertently encourage the use of the emergency department for non-emergent issues. So as the speaker mentioned, we have spoken to her about this issue. We are looking forward to working on potential language for this bill, and thank you for giving us the time to speak today.
Good afternoon, Madam Chair, committee members. My name is Tina Quigley, and I'm here today on behalf of Care First. Like my colleagues on this panel, I also vote to be opposed to the speaker's bill, but we do appreciate her introducing the bill and focusing on improving emergency department performance and care transitions, and we welcome the opportunity to continue working with this committee to address our concerns. Our goal is to support the intent of the bill while avoiding unintended consequences. Just with respect to the prudent layperson standard, as you mentioned, Madam Chair, and has also been mentioned, Maryland was the first state to adopt the prudent layperson standard in 1993, and it was later incorporated into federal law in 1997 for Medicare and Medicaid. So today it's widely accepted nationwide, and the principle is pretty straightforward. Individuals should not be expected to self-diagnose or determine the medical severity of their condition before seeking emergency care. So we are concerned about moving away from this framework, that it could lead to increased use of emergency departments for non-emergent conditions, and that could in turn worsen overcrowding and increase boarding and drive up system costs, outcomes that none of us want. So we respectfully ask the committee to consider our concerns, and we look forward to working collaboratively on potential revisions that will preserve patient access and preserve the prudent layperson standard in Maryland law. Thank you.
Thank you for your testimony. I'm going to open it up to questions from the members. Delegate Kaufman.
Yes. Could you see a scenario, though, where somebody needs to go to the emergency room, particularly if it's like 3 a.m. and urgent care is closed, but they don't go because they're worried that it won't be classified as an emergency medical condition, they'll get stuck with a bill of thousands of dollars. So I understand your point, but could you see that could you see it having the opposite effect where people need emergency care but they don't go for fear of being stuck with the bill?
I think we certainly don't want that scenario, and as I did bring back that scenario to Kaiser, they say they would not want that either. So,
thank you, Madam Chair.
Delegate Hill.
Thank you, Madam Chair. Tina, this is for you. I really appreciated your testimony. I appreciate all your testimony, but I appreciated your sort of empathy with what patients are experiencing. So my question is, you're an experienced professional. What can or what might insurers or the community at large do to A, increase coordination between various types of facilities so that there's some clarity about who covers what things and is best suited to take care of what kinds of problems, or not even the types of problems, but what kinds of presenting complaints, right? Because you don't know what the problem is until it's diagnosed. And what might they be able to do to educate the public about this is what's appropriate for the nurse's line. This is where it's appropriate. If you have these symptoms, this is calling for an ambulance. I don't see that education piece. I just see the patient went to the wrong place, so we're not going to pay.
With respect to, increasing coordination, that's something I think that we all we as carriers, struggle with the providers, and when they refer patients who may no longer be in an acute situation. but may need further care. Unfortunately, I will have to take that back to the company to see if we have some more ideas with respect to how to increase and specifically to make sure that the coordination of care happens.
For the emergency situation?
Yes, for emergent
Thank you.
situations. Yes.
Seeing no further questions, I just wanted to ask a question. And I know you're in the hot seat right now, but it sounds like you're ready to work with the speaker, because the opposition, I understand, based on the prudent layperson standard, which does say requires insurers to cover emergency care based on a patient's presenting symptoms, not the final diagnosis, correct? And it does speak to downcoding, that we can't retroactively deny claims or change, claiming the final diagnosis was not an emergency. Like, that's current law. And we did pass this first, but I think there is a concern that perhaps there is slippage, and maybe it's time to revisit that law and that standard to ensure, to the speaker's point, that there is teeth in it. Because I think, to Delegate Hill's point, I don't think it's a reasonable belief that people are going to the emergency rooms waiting 8, 10, 12 hours for what they do not truly believe is an emergency. Isn't that so?
Yes, Madam Chair.
Thank you. So I'm assuming that you are going to continue to work with the speaker to find that sweet spot where we can make sure that that we are adhering to the standard, giving it teeth, but also unsticking some of these very challenging ER wait times, because it is the standard in 47 states, but we remain the state with the worst ER wait times. Thank you very much.
Thank you.
Thank you for your
Thank you.
testimony. Delegate Taveras.
Yes. Sorry, I was sitting in another bill, but thank you. So I've been hearing a lot of the conversation in the back, and I was just wondering, how is this not, or is it cherry picking? That way you take the winners and let go of the losers, and improve your overall outcomes.
I think, and I'll defer a little to my colleagues, I don't think this is necessarily cherry picking. I think this is really an effort to maintain the current standard, and to make sure that we are not encouraging ER use for non-emergent issues.
Well, I mean, if people have no other place to go.
And I think that's, as my colleague mentioned, that is not necessarily what we would consider a non-emergent issue if that is the only place open.
Thank you very much for your testimony. This does conclude the bill hearing on House Bill 1563. I trust you. I know that you're going to continue to work with Madam Speaker and with our committee so that we can get there. We're going to now move to House Bill 1055. This is Health Newborn Screening Program, Goucher disease. Delegate Solomon, if you want to come to the table and bring your panel, and you can begin your testimony. And Delegate Solomon, I'm correct, you have one virtual witness on your panel, is that?
Two, actually.
Two?
Our student unfortunately could not make it down here, so she is virtual.
Oh, is that
Madeline.
Madeline Slosh? Okay. Thank you. So we'll bring up Madeline Slosh.
I think she's already in the waiting room, I think.
And Aviva Rosenberg. We'll bring them up as part of your panel.
Thank you, Madam Chair. I'm glad I got to follow the insurance lobbyist and not the speaker, so that was good. It's good to be back here. I think I've been in health the most, actually. I have a couple of more bills next week. But for the record, House Bill 1055, Delegate Solomon here to present 1055 from District 18, which is a newborn screening program addition for Gaucher's disease. I want to just start off from the outset by saying, I think especially those of you who have been here for a little while know that we often put in bills for a variety of different reasons, many of which are often to raise awareness, to start a conversation, to make sure that our colleagues learn about an issue that they may not know about. And we often do put bills in knowing full well that we don't intend to pass them or have them become law, that there are other processes, but these bills start a conversation. And so I think I want to start from the outset because the opposition testimony here is that Maryland does not legislate these items, which we have a very robust public health infrastructure that is one of the best parts of our state. And we are not trying to upset that apple cart. I think similar to some of the conversations that we often have, my background's in education, some of the discussions we often have around curriculum issues, it's the same kind of thing. We typically do not legislate curriculum. That has been a longstanding rule in the General Assembly for many years, but it starts a conversation. It starts a conversation between the state board and MSDE and the community. And that was the intent behind this bill. We have been working with the Maryland Department of Health that oversees the newborn screening panel. Our good colleague, Delegate Hill, I know has a bill that is looking at maybe tweaking that process a little bit, and also is the House's representative on that committee, and appreciate her really wise and sage counsel on this issue as well. So I just wanted to get that on the record from the outset that, again, the intent of this bill is not to jam anybody or to override the public health procedures that we have longstanding have in place. It's really to elevate the issue and make sure that you're all aware of it and that we show the support that we have from the community. So with that, let me talk a little bit about what the bill does or would do and why we're here. So this would be to add Gaucher's disease to the newborn screening panel. What is Gaucher's? I'll give you just a quick overview. There's a lot more detail in the submitted testimony. It is a genetic condition that leads to a fatty buildup in tissue and organs and can lead to organ dysfunction and failure and bone dysfunction. And the reason why I am here today is there's a couple of reasons. One, I am the House co-chair of the Jewish caucus, and Gaucher's is actually the most prominent genetic disorder in Jewish community, particularly in the Ashkenazi Jewish community. And Maryland has, we are top 5, depending on how you do the percentage or you do it by raw number, but we are we have one of the largest Jewish populations of any state in the country. And again, this is the most prominent genetic disorder that affects the Jewish community. I'm also here because my mom had Gaucher's. She had type 1, and actually she did not discover it until she had a incredibly serious ankle fracture when I was a teenager. And we discovered that part of the reason her bones were a little bit more brittle than they should have been was because she had Gaucher's. I don't know that if she had been screened as a newborn, whether she would have clearly found it earlier. On her age, there probably wouldn't have been a treatment available at that point. But what we are trying to do here is there are treatments available that significantly enhance quality of life. There's different types of Gaucher's, one of which is fatal, usually within the first couple of years of life. But for the other 2 types, treatment, and particularly early treatment, makes a huge difference. And so again, we want to be able to lift this up. This was personally important to me when it was brought to us by the community, and you're going to hear from one of our amazing advocates who's a student at College Park and a resident in Baltimore County. But this was really personally important to me and was a top priority for the Jewish caucus this session. The last couple of points I'll make before I turn it over to the panel, there already are 2 lysosomal disorders that are part of the newborn screening panel. So you'll notice in the fiscal note, there isn't really much of a cost, and we did have a conversation. I participated in the newborn panel meeting last week. If this eventually is added through the panel process, they are a little concerned that they may need some more money to notify families, but the actual process of adding this to the panel does not require new equipment. It literally just requires sort of turning on a testing indicator in the equipment that they already have for the 2 lysosomal disorders that are there. There are a number of states, and you'll hear from the other panelists, that have added this to their panel within the last couple of years, and there are 2 letters in your testimony, one from the American Jewish Medical Association and the Jewish Orthodox Women's Medical Association in support. And again, we are continuing to work with the community, with the Department of Health and the screening panel to talk through issues, to make sure they have all the information as they complete their review and do their scoring. But again, we really just wanted to lift this up. So I've never not asked for a favorable report, but again, our intent is not to upset the apple cart, but just to make sure that you know the issue and that you know that this is a real priority for our community. So thank you all.
Good afternoon, Madam Chair, members of the committee. For the record, Abby Snyder, Director of Government Relations for the Baltimore Jewish Council, which represents the Associated Jewish Federation of Baltimore, all of its agencies, and the organized Jewish community of the greater Baltimore region. We are here today in support of HB 1055, or whatever version gets this across the finish line. This disease, as Delegate Solomon said, is the most common Jewish genetic disease, and that's why we are here. 1 in 10 Ashkenazi Jews are carriers of this disease. And though we are certainly not medical experts at the BJC, we have learned that, as Delegate Solomon said, adding this test to the newborn screening panel really is simple, turnkey, add it to the list, and comes with a really small fiscal note. So we're hopeful that in whatever way the committee or the Department of Health, what have you, sees fit, that this can be an easy addition to the newborn screening panel. So thank you.
Thank you for your testimony. We're now going to go to, do you want to go to Madeline?
Yeah, Madeline and Aviva.
So
yeah.
Madeline Schloss, if you want to go ahead and unmute, and you can begin your testimony.
Perfect. Hi, I am Madeline. I am 24 years old and I live in Pikesville, Maryland. I was diagnosed with type 1 Gaucher disease when I was 5 years old. And my dad actually knew he was a carrier, so my mom got tested when she was pregnant with me, and she was misdiagnosed as a non-carrier. So when I was born, obviously not being screened for Gaucher disease because it wasn't on the newborn screening panel, I was not tested because it was thought that I couldn't have Gaucher disease. So when I was 5 years old, I went to my pediatrician for a random cough, and she was able to feel my spleen, which was an immediate emergency, and it was a pretty long diagnostic journey to figure out that I had Gaucher disease because my mom was told that she wasn't a carrier. So little 5-year-old me went through millions, what felt like millions, of blood tests, MRIs, scans, anything you can imagine for over a month to then figure out I had Gaucher disease, which at that point, finding out that I had type 1 Gaucher disease and that there was treatment available felt like a blessing because of all the things that it could have been. So the fact that there was treatment available was really nice. But to think that those weeks, almost months long of the diagnostic journey could have been completely eliminated with a newborn screening test just really baffles my mind, especially when there are multiple other states that have been doing this test for over 10 years now. So including myself, I know multiple other patients within the Baltimore community that have had similar diagnostic journeys, honestly, way longer and way later in their life as well. So yeah, just from my experience, my family's experience, it seems like a no-brainer to us to add Gaucher disease to the newborn screening panel. Obviously, I'm coming from a patient voice, not a scientific background, but yeah, just to think that that journey could have been minimized from adding this to the panel is really inspirational, and I think it would be a great addition for the state of Maryland. Thank you.
Thank you for your testimony. Ms. Rosenberg, if you want to go ahead and unmute, you've already done, and you can begin your testimony.
Thank you, and thank you for having me. My name is Aviva Rosenberg. I'm the CEO of Gaucher Community Alliance, which is the national patient advocacy organization for Gaucher disease. I'm also a type 1 patient, and I'm the mom to a teenage son who also has type 1 disease. So Gaucher disease is a multi-system disease, and it leads to a whole spectrum of disorders. So some of you've heard organ dysfunction, bone dysfunction, and including neurological decline. We've had treatment that's FDA approved since birth, since 1994. So this is not a new disease. And the average diagnostic journey for Gaucher patients is 7 years. My own personal journey was over 20 years. So the timing of treatment initiation has a significant impact on the clinical outcomes. And when treatment is delayed, it can cause irreversible complications that children and families can never get back. So early intervention with FDA-approved treatment is the best possible chance for a normal life and the best outcomes. As Madeline alluded to, States have been screening for this newborn screening test since 2013. Missouri was the first one to begin in 2013. Illinois followed the following year in 2014, and numerous other states screen for this disease. This is not new technology. This is not new treatment. There is really nothing cutting edge about this program. And especially in Maryland, where we know there's Ashkenazi Jewish families that are probably wondering why their child is breaking bones or why their child is having bloody noses. This seems like a very easy addition to be able to stop the worry of the families that are going for many, many years with no diagnosis. And so I would encourage you to please help Maryland families get appropriate diagnosis and treatment before they face irreversible complications. Thank you for having me.
Thank you for your testimony. I'm going to open it up to questions from our members, starting with Delegate White Holland.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill and for your panel. And pardon me if you might have shared this, but just from a historical perspective, has there been any and all those who have Gaucher's disease advocated for this to be included in the past through the existing process? And just would like to, get a better understanding if, because again, I'm thinking about some of the other newborn screening bills that this committee has heard in the past, and I recognize the unfavorables have elevated that there is an existing process. So I just wanted to get a sense if this has been advocated through the nomination process before.
Yeah, so it's actually, well, first of all, Delegate, thank you for the question. It is actually currently working its way through. So that process has been in process, and I know Aviva and Madeline have been intimately engaged in it since, I believe, the late fall. And so there was a expert presentation. They meet, I guess, the fourth Wednesday of every month. So last Wednesday, I participated in it to just share that we supported the committee's action. They have not finished yet. So we had a follow-up conversation with MDH. They have another expert that is going to present, I believe, in March, the end of this month. And then in April, they believe that they have a rubric scoring process that they'll begin to go through. So, we sort of wanted to do this in concert with that to lift up the issue. And again, that's why I said from the outset, and my understanding is that the process to allow the community to bring issues is relatively new. I think newer, ish, maybe not. I see you're shaking your head, so I'm not 100% sure what the process was, but I know there is an ability for the community to bring them.
Okay, thank you.
Seeing no further questions, thank you very much for your testimony. This concludes, I'm making sure, this concludes the bill hearing on House Bill 1055. We're actually going to go to House Bill 1042. Thank you very much for your testimony. House Bill 1042, which is, we are actually not going to go to that bill. We are going to go to 1092, Delegate Martinez, because that's who we have here right now. So Maryland Department of Health, Adolescent Psychiatric Inpatient Beds Capacity in Prince George's County and Report. Delegate Martinez, thank you very much for your flexibility. If you want to approach the table and go ahead and bring your panel, and you can begin your testimony.
I leave my panels in my office as I talk and walk.
Yep. You can just talk and walk and text and
I need to actually call my staff. Now I can't find the number. Here we go. Is he listening? Oh, hello. Yes. All right, come on.
Yes.
And then there's one other person that will be joining us as well. Okay. Very flexible. All righty. Well, Madam Chair and members of the Health Committee, for the record, I'm Delegate Ashanti Martinez, here to present House Bill 1092, Maryland Health Department Adolescent Psychiatric Inpatient Bed Capacity in Prince George's County and Report. This bill provides 24 beds for adolescent ages 12 through 16 for overnight psychiatric evaluation, and treatments. It would also establish a public-private partnership to finance and operate these beds, improving access for any child regardless of insurance status. Prince George's County is currently experiencing reductions in its capacity to serve adolescent psychiatric needs. Moreover, there have been multiple issues noted by state and local health officials, ranging from patients with prolonged stays in psychiatric care facilities, inability to transfer patients to specialized care units, and a general lack of availability for overnight care. This bill would increase the number of available psychiatric beds by 24, greatly increasing the county's capacity for care and alleviating the mentioned issues by allowing for a greater flow of patients who will be served. Additionally, the cost of operation and improvement for these 24 beds would be offset by the establishment of a private-public partnership, allowing for the burden of cost to be reduced and to be more focused on the actual care. Prince George's County Council members, residents have voiced concerns about the existing system's capacities in addressing mental health issues, especially the shortage of inpatient beds. Currently, capacity in Prince George's County is woefully insufficient, with the University of Maryland Capital Region Medical Center as the only hospital in the county that offers inpatient beds for adolescents at a grand number of 2. It is estimated that as many as 200,000 adolescents throughout the state of Maryland struggle with their mental health, and with at least a fourth being unable to acquire treatment of some kind. To show the impact of the shortage of adolescent psychiatric beds, one of my constituents, Danielle, who is in my office and coming up to talk to us today about her daughter, Patience. Patience was adopted in 2017, and due to a number of unfortunate circumstances and traumatic experiences, she had the grave misfortune of needing to be hospitalized for mental health care over 10 times. To me, her lack of being able to find a bed in Prince George's County is a failure of our county and our state, and that we deserve to have life-saving care for children who are extremely vulnerable. To restate, this bill would allow for the creation of 24 more overnight psychiatric beds throughout Prince George's County. The beds would allow for a considerable gap, would allow to close a considerable gap in care, as well as improve conditions for our adolescents seeking care. For those reasons, I strongly urge a favorable report on House Bill 1092. And this is Jabari from the Prince George's County Council.
Ooh, sorry, Monique. Greetings, Chair and members of the Health Committee. On behalf of the my name is Jabari Cooper, Legislative Officer and Committee Director here on behalf of the Prince George's County Council, and we respectfully request a favorable report on House Bill 1092. House Bill 1092 will require the Maryland Department of Health to ensure that the establishment and ongoing operation of minimum number of licensed adolescent psychiatric inpatient beds in Prince George's County, and to evaluate options for expanding capacity when needed. Prince George's County is home of one of the largest youth populations in the state, yet families continue to face significant challenges accessing timely inpatient behavioral health services for adolescents experiencing acute mental health crises. Limited bed availability often results in extended emergency department boarding, delayed treatment, and families being forced to seek care outside of their home jurisdictions. Expanding local inpatient capacity is essential to ensuring that youth receive appropriate, timely care in the least disruptive setting as possible. House Bill 1092 addresses a critical gap in Maryland's behavioral health infrastructure by prioritizing geographic equity access to inpatient psychiatric services. Ensuring sufficient adolescent bed capacity with in Prince George's County will help reduce strain on emergency departments, improve continuity of care, and support better outcomes for youth and families. Increased local capacity also enhances coordination with community-based providers, schools, and family support system, which are all vital components of effective behavioral health treatment. From a local government perspective, improving access to adolescent behavioral health services can also reduce downstream impacts of public health safety systems, school systems, and social services. Where youth are unable to access appropriate care in a timely manner, local systems often absorb the consequences through increased crisis response demands and service utilization. House Bill 1092 represents an important step forward towards strengthening Maryland's behavioral health continuum and ensuring that Prince George's County residents have equitable access to needed services. The Prince George's County Council supports efforts to expand behavioral health services and capacity and to improve the mental health crisis. For these reasons, we request a favorable report for House Bill 1092. Thank you.
Thank you for your flexibility.
Thank you. Thank you. To the members of the committee, I want to really thank Delegate Martinez, who is my wonderful delegate from District 22. And as I told him earlier, is quite frankly giving me some hope as a mom who's been raising a kid with significant mental health issues for the last 9 years. My name's Danielle LeClaire, and I am testifying today in favor of HB 1092, which would finally bring critically needed mental health services for kids in Prince George's County, as well as expanding, by extension, mental health care to all kids in Maryland. As Delegate Martinez said, I adopted my daughter from foster care. We should be promoting foster care adoption, and yet once we do adopt and the kids have significant health issues, we as moms and dads are left alone in the wilderness. And unfortunately, my great kid had a really significant history of trauma and abuse in her birth and foster homes. And she's needed a number of mental health hospitalizations, despite trying to get her good therapy along the way. We live in Prince George's County in University Park. There are currently actually 0, unless it changed in the last few months, mental health inpatient beds. There were a couple of ER beds, which was frankly scary because my daughter was admitted to that one or waiting in the ER at that facility. And there's not a locked door between the kids are and the adults are. So adult men with mental illness could just walk through an unlocked door to access my child, which did happen in the weeks, plural, that she was there. These sorts of things have made it even worse for her. She's boarded or overstayed many times in the ER. Most of these places do not have pediatric emergency areas at all, mental health or otherwise. So that means that my child, my minor child, was seeing people come in who had been in car crashes, heart attacks. Again, adults having mental health crises and running around naked and cursing and screaming in the ER. These further traumatized her. My daughter, because of the shortage of inpatient hospital beds for kids in Maryland, my daughter's had to go to DC, Pennsylvania, and even Utah for mental health treatment. It's just completely unacceptable. And even when she was able to be admitted to a hospital in our state, she's been, an hour or more away from home in Baltimore City and Calvert County. Look, may I have 30 more seconds? Thank you. Again, as a worried mom, you don't want to be driving a couple hours round trip to see your kid in an ER. It's a really scary situation. This would mean that kids in Baltimore could get treatment in Baltimore or closer, kids in Southern Maryland, in that area. The last thing I want to say is it was a really scary time. My daughter had multiple hospitalizations in a very short time. We were told there was still nowhere for her to get mental health treatment. Because she's also developmentally disabled, DDA offered us an apartment in Baltimore with one contracted out staffer that would sit outside her door. She was a child. Ultimately, I said no, and frankly, Delegate Martinez and our county council member and others helped me. But when I heard about Kenai Ward's death last fall, I burst out in tears. That child was only offered a hotel room instead of mental health care. She's also from Prince George's County. She was only in foster care because she couldn't get mental health treatment. She wasn't abused, she wasn't neglected. Same with my daughter. We have got to stop offering apartments, hotel rooms, these really scary, dangerous situations to kids with mental health care. They need to be in a hospital. So I am, as a mom, as somebody who talks to all these parents, I am begging you. I'm begging you to pass HB 1092 this year. We can't wait. We can't have any more of our kids die. So thank you very much for considering the bill.
I have a Stephanie Slowly Little on your, you can come to the table and give your testimony.
Good afternoon, Chair Bagnall, Vice Chair Collison, and distinguished members of the Health Committee. I'm here in full support of HB 1092 to the tune of running over in the rain. I'm a member of Prince George's County. I've been there my entire life, but I am also the Executive Director for NAMI Maryland. It is vitally important that we utilize this as a catalyst to support our youth in Prince George's County. As a resident and a mom, there are no places for our children to go, period, hard stop. If I have an issue with one of my young ones, someone that I'm servicing, or a member of my organization, there's nowhere for them to go. And to have them drive hours upon hours to get services is hard. when you're talking about individuals that I represent, families that I'm here to support, that have to deal and conflate with a system that it's hard to navigate through, people who do not have the resources to do so and are trying to work and take care of their loved ones, it is too hard. I urge this committee, on behalf of myself as a mom, a resident of this county, an executive director who is fighting every day for across the state for the 60,000 members, families, and advocates that are working in the area of mental illness, please let's work together and support this bill because our children's lives are at stake. The stakes are too high, and the only investment is yes. I thank you for the time.
Thank you for your testimony. And before I open this up to questions from the members, first of all, I want to say thank you, and we hear you. But second of all, I want to say that this bill is not the only effort that we're making. And I need to put that on the record because there are some challenges that we're going to have to address, but we have a pediatric overstays bill. We have a VPA bill. We have Kiara's law. We have a number of efforts and funding, and we are navigating all of those and how they intersect. So I just want to make sure that it is very clear that this committee and this body takes this very, very seriously. And with that, I'll open it up for questions. Delegate Kaufman.
Thank you, Madam Chair, and thank you for your powerful testimony, and Danielle in particular, I'm rooting for your daughter. I wanted to ask the sponsor a question. Have you had a chance to read the Department of Health letter of information, and are you amenable to the study they desire?
I have not read it. We received it yesterday evening, so I hadn't had a chance just yet to read all of it over. But we're amenable to the solutions because I think Madam Chair spoke really eloquently to the fact that this is a full court press. All the solutions on the table are worth exploring.
I'll email it to you. Okay.
Thank you.
Delegate Tavares.
Thank you. This is, hi, thank you. This is a really important problem, obviously, in our county, because you're right. I'm somebody who represents Prince George's as well. I can definitely understand that this is a big issue. How is this being separated from the substance use disorders? Or is it the same beds?
These would be separate beds. This is not, this would not be included in for, I know you do a lot of work around children with substance abuse. This would be separate from that.
Okay, just making sure because there's already money at the table for those kinds of issues. And I thought that there was a center, Dinette Center, maybe I'm mispronouncing.
So yes, so the Dinette Center is in my district. I don't know that they have medical facilities or beds available. I know they have a gorgeous mosque. It's one of the largest in the country, and they also have community rooms and spaces, but that's the only Dinette Center I'm aware of.
No, I'm talking about this facility down south in South County.
I'm not
That's a 24-hour facility.
Delegate Tavares, can you ask your question?
Sorry, yes. I don't know, are you aware of this facility for psychiatric care in South County?
I am not, and if you have information, please send it via email. We would love to know more.
May I say something?
Will do.
One question.
Seeing no further questions, I just want to, again, thank you for your testimony. And Delegate, I'm going to encourage you to work with the department. There are some concerns about operationalizing this and the realities of bed capacity is not always the challenge that we're facing. We're facing a workforce issue with acuity and partnering acuity with the workforce. And I would also encourage you to work with our Madam Speaker, who also is navigating the pediatric overstays recommendations from the work group that I believe this committee and appropriations passed last year. This concludes the hearing on House Bill 1092. Delegate, do you want to just proceed to your next bill?
You know, I'm already here. It's quite comfortable, and I just got my testimony.
All right, so let's go ahead and proceed to your next bill, which is House Bill 1114, HIV prevention drugs, prescribing, dispensing, and insurance coverage. If you want to bring your panel to the table, and you can begin your testimony.
Well, thank you so much, Madam Chair and members of the Health Committee. For the record, I am Delegate Ashanti Martinez, here to present House Bill 14, HIV prevention drugs, prescribing, dispensing, and insurance coverage. Before I talk about the policy, I want to talk about my own experience. PrEP is not just a public health tool, it is very personal. When I first asked my former primary care physician about PrEP, I remember feeling the weight of stigma in the room. The questions that he asked didn't feel clinical, they felt very much judgmental. The implication was that asking for PrEP somehow said something about my character rather than my commitment to protecting my health. That moment stayed with me, and unfortunately, it is not unique. Many people who could benefit from PrEP hesitate to ask for it because they fear that for that same kind of reaction, that asking for prevention somehow invites shame. But prevention should never be something people feel embarrassed about. It should be encouraged. My own experience is one of the reasons I have become such a strong advocate for expanding access to PrEP. When people take proactive steps to protect their health, public policy should meet them halfway, not create additional barriers. That's exactly why House Bill 1114 is so essential. For those unfamiliar, PrEP, or pre-exposure prophylactic, is one of the most effective HIV prevention tools that we have today. It can be taken as a daily pill or as a periodic injection, and when used as prescribed, can reduce the risk of HIV infection up to 99%. Yet despite its effectiveness, barriers still exist. Even small costs discourage people from filling prescriptions. Research shows that even a $10 copay can double the number of PrEP prescriptions that go unfilled. House Bill 1114 removes those barriers by ensuring that Medicaid, insurance carriers, and managed care organizations provide coverage for FDA-approved HIV prevention medications, including both PrEP and post-exposure prophylaxis, or PEP, without unnecessary administrative hurdles. Specifically, the bill prohibits prior authorization, step therapy requirements, and cost sharing, meaning no copays, coinsurance, or deductibles for PrEP medications or the services required to safely use them. Those services include HIV testing, routine monitoring, provider visits, and testing for other related conditions. There's also a sponsor amendment that we sent to the committee for this bill. The amendment removes the provisions related to pharmacist prescribing authority, as that issue is actually addressed in separate legislation that we will hear today. Instead, this bill has been streamlined to focus on what assets I truly think matter, which is ensuring coverage for PrEP, as well as a second amendment that includes testing for hepatitis A. This approach keeps this bill simple and focused on expanding access to prevention. The fiscal note you will see for the legislation also highlights why prevention matters. Medicaid already covers several PrEP medications, including Truvada, Descovy, and Apretude. While the fiscal analysis notes that expanding access could increase utilization in the near term, it also makes clear that preventing HIV infections will likely produce long-term savings because lifetime HIV treatment costs far exceed the cost of prevention. In other words, prevention is not just good public health, it's also smart fiscal policy, and the need is real. Today, more than 32,000 Marylanders are living with HIV. And our state, unfortunately, infection rate remains highest in the nation in terms of average. We also know that HIV does not affect all communities equally. Although African Americans represent about 30% of Maryland's population, they account for approximately 74% of the people living with HIV in our state. Gay men also remain disproportionately impacted, representing about 42% of new diagnoses, even though LGBTQ adults make up such a smaller percentage of our state's population. If we're going to be serious about reducing these disparities, expanding access to preventative tools like PrEP is essential. House Bill 1114 is a practical evidence-based step forward. By improving coverage and eliminating financial barriers to prevention and testing, this bill helps ensure that Marylanders have the tools they need to protect their health and prevent new infections. Public health works best when prevention is accessible, stigma is reduced, and people are empowered to take control of their health care. House Bill 1114 helps us move in that direction, and for those reasons, I respectfully urge a favorable report.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. For the record, my name is Ronnie Taylor, and I serve as the Community Impact Director at Free State Justice. I appear in support of House Bill 1114. This bill allows pharmacists to prescribe and dispense HIV prevention medications like PrEP, eliminates insurance barriers that delay access to care, mandates coverage of FDA-approved HIV prevention drugs, and eliminates prior authorization and cost sharing that hinder timely access. You might hear about other versions of this legislation or proposals for different amendments. What matters most is that Maryland implements a policy that genuinely increases access to prevention. House Bill 1114 accomplishes that. From a public health standpoint, prevention only succeeds when people can access it promptly. Delays caused by insurance obstacles or limited provider access weaken HIV prevention. From a legal standpoint, Maryland has a duty to eliminate structural barriers that hinder preventative health care. Allowing pharmacists to prescribe PrEP according to CDC clinical guidelines enhances the state's efforts to end the HIV epidemic while keeping safety standards intact. In communities most impacted by HIV, many individuals lack a consistent primary care provider, depending on urgent care clinics or pharmacies for their healthcare needs. Pharmacies are often the most accessible healthcare setting and serve as the first entry point in prevention. At Free State Justice, we see clients delay their prevention because they cannot secure timely appointments or find affirming providers. Expanding pharmacist authority allows people to begin prevention immediately while still connecting them to follow-up care. For these reasons, I respectfully urge a favorable report on House Bill 1114.
Thank you very much for your testimony. I'm going to open it up to questions from the members. Seeing none, thank you very much for your testimony and for the bill and for pointing out the fiscal note. I have a favorable panel, which I've just lost my notes. Oh, here we go. So let me bring Charlotte Hoffman, and then we also have 3 virtual favorable witnesses. Okay. Sharon Coker, and Emern Awinga is not in the waiting room. Okay, and Justin Rush is not in the waiting room. Okay, so if we can bring up Sharon Coker and bring Charlotte Hoffman to the table. Charlotte? Okay. All right, so we will bring up Sharon Coker. If you want to unmute and begin your testimony.
Good afternoon. My name is Sharon Coker, and I am the Executive Director of SLK Health Services Corporation, a 501c3 community-based organization focused on HIV prevention, psychosocial support, and treatment for people living with HIV. I live in District 23, a community that continues to carry on one of the highest rates of new HIV infections in Maryland. In my district, too many neighbors remain at risk, not because prevention doesn't exist, but because access is delayed, complicated, or wrapped in stigma. I strongly support this legislation to allow pharmacists to prescribe PrEP, ensure Medicaid covers FDA-approved HIV prevention drugs, and eliminate prior authorization, step therapy, and cost sharing. These barriers create delays, and in HIV prevention, delay can mean infection. But because access is not enough, implementation must include mandatory cultural humility training for pharmacists and providers. No one seeking PrEP or PEP should feel judged, interrogated, or shamed for protecting their health. Let me be clear, taking PrEP is not a moral failure, it is a public health success. People should never be stigmatized because of what they are prescribed. Prevention is responsible. Prevention is proactive. Prevention saves lives. By requiring the State Board of Pharmacy to develop a notification plan and convene a work group, we have the opportunity to ensure that this is done safely, equitably, and with a dignity at the center. I urge the committee to give this bill a favorable report. The question is not whether prevention works. It does. The question is whether we are willing to make it accessible with dignity. Thank you.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much for your testimony today. We do have a favorable with amendments, so Aaliyah Horton, and we also have Amit Mickey Dur virtually. So if we can bring up Amit Dur, and Ms. Horton, you can begin your testimony when you're ready.
Yes, good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association, and we are here requesting a support with amendment. Delegate Martinez already indicated that he would work with us on the bill to remove the pharmacist scope piece from the legislation because it is addressed in House Bill 1150, which we'll be talking about later today. We 100% are behind increasing access and increasing coverage for HIV prevention medications. And so I'll leave it at that. I think the previous speakers have really covered the need for the bill, and happy to answer any questions.
Thank you for your testimony. And do we have Amit Mickey Dur? If you want to unmute and begin your testimony.
Everyone, can you hear me?
Yes, we can.
Okay, great. Hi, this is Mickey Dur. I'm a clinician specializing in HIV prevention and care here in Maryland, and I serve as a commissioner and chair of Health and Wellness Committee of the Maryland Commission on LGBTQI+ Affairs. Thank you for the opportunity to testify today in strong support of HB 1114. The commission is in alignment with the sponsor, and we appreciate the conversation we've had with the sponsor's office regarding the bill and the proposed amendments. We support the sponsor's efforts to move this legislation forward and expand access to HIV prevention in Maryland. As a frontline provider working with patients across Baltimore and surrounding communities, I see firsthand barriers many individuals face in accessing HIV prevention services. Many patients who could benefit from PrEP never reach a provider due to structural barriers such as insurance challenges, cost, transportation limitations, stigma, and lack of access to culturally competent care. These barriers are also reflected in my recently published systematic review examining PrEP uptake among men who have sex with men and transgender women in the United States. The review found that uptake is strongly influenced by structural and social factors, including financial barriers, limited provider knowledge, stigma, medical mistrust, lack of access to culturally competent or gender-affirming care. Even as PrEP awareness has grown, misinformation and uneven access continue to limit uptake and persistence among vulnerable populations. For these reasons, policies that reduce administrative and financial barriers to HIV prevention medications are critical. HB 1114 takes important steps in that direction by eliminating prior authorization, step therapy, and cost-sharing requirements for PrEP and PEP, which remain some of the most significant barriers to timely initiation and sustained use of these medications. Reducing these barriers will improve equitable access to HIV prevention for our communities that continue to be disproportionately affected by the HIV epidemic. From both a clinical and a public health perspective, expanding access to prevention medications is essential if Maryland is to reduce new HIV diagnosis and improve health outcomes. On behalf of the Maryland Commission on LGBTQI+ Affairs, we thank the sponsor for the leadership on this issue and respectfully urge a favorable report on HB 1114. Thank you.
Thank you for your testimony. Are there any questions for these witnesses from the members? Seeing none, thank you both very much for your testimony today. We do have one unfavorable. Sarah Case-Perrin, I feel like you drew the short straw today. You can come to the table and go ahead and give your testimony.
Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. Oh, my apologies. The joys of being short. Good. Yes. Good afternoon, Chair Bagnell, Vice Chair Collison, and members of the Health Committee. Thank you for acknowledging the difficulty of opposing, of being unfavorable on this bill respectfully. I want to state first, my name is Sarah Case-Heron, and I'm here representing the League of Life and Health Insurers of Maryland. I want to state initially that the League and carriers believe in, support, and encourage the use of HIV prevention drugs, but simply oppose the House Bill 1114 as currently drafted. And I do want to take a moment of personal privilege to thank the delegate for discussing his experience and the stigma he has seen. The majority of HIV prevention drugs are currently covered by health insurance. However, as currently drafted, this bill would require carriers to cover all such FDA-approved drugs without cost sharing, which is a significant coverage change that could have a correspondingly significant impact on rates and also disincentivize the use of generic drugs. As technology evolves, new drugs are being approved for HIV and other conditions regularly. While this is wonderful, it often does lead to drugs that may have a higher cost, at least initially. By requiring coverage without cost sharing of all FDA-approved drugs, this bill could incentivize the use of the newest and most advertised drugs while eliminating important cost-saving measures. Again, the League sympathizes with the goal of increasing HIV prevention drug use, and we agree with that goal. We welcome the opportunity to discuss ways to encourage use of HIV prevention drugs while maintaining necessary cost-saving measures. Again, we're not opposed to the intent of this legislation and are more than willing to work with the committee and the sponsor to address these concerns. Thank you for your time and your consideration.
Thank you for your testimony. Are there any questions from the members for this witness? Let me start with Vice Chair Collison.
Thank you, Madam Chair, and thanks for being here, Sarah. You said that most carriers are now covering and potentially with a cost share. Is there a mandate for coverage or no?
There is, I believe, a federal requirement for some coverage, yes.
And is it particular drugs, or it can be any drug that the federal government
I believe
covers?
it can be certain drugs, yes.
Okay, we'll talk about that more.
Yeah.
We have one last. So do you think that there's a way forward on this bill, if we could do some discussion around what the particular, to put some limitations around the cost implications?
Absolutely. I think that we would welcome the chance to discuss a way forward on this bill.
Okay, great. Thank you very much.
Thank you very much for your testimony. This does conclude the bill hearing on House Bill 1114 and allows Delegate Martinez off the hot seat. Madam Vice Chair, are you ready to proceed? All right, then we're going to proceed to House Bill 1119. This is Health Occupation Social Worker Scopes of Practice. Vice Chair Collison, if you want to approach the table and bring your panel, and you can begin your testimony when you're ready. Thank you. And just for planning purposes for the members, this is Bill 5 of the 13 bills we're hearing today.
It may just be me, Madam Chair.
You are not.
Thank you. Good afternoon, Madam Chair, members of the committee. It's nice to be home. I've been down in Judiciary. And by the way, it is very warm in Judiciary, so just in case you were wondering. Thank you for the opportunity to present House Bill 1119 today. It's the Health Occupation Social Workers Scope of Practice. You know, over the last couple of years, we've been working on, particularly on the licensing processes for social workers. And in that work, we've discovered that the regulations around the scope of practice for our, the statute and the regulations around the scope of practice for our social workers is really old. Maybe not as old as me, but it's really old and needs to be updated. And that's what this bill attempts to do. What it does is it is clear that the licensed bachelor social workers would be able to perform vital generalist work such as psychosocial assessments, case management, client advocacy, that the licensed master social workers are able to perform functions of the previous category, as well as conduct assessments and develop treatment plans. And then the highest level, the licensed certified social worker clinical, can practice independently, provide advanced diagnosis and treatment. It also reflects today's challenging reality, writing in the use of telehealth, electronic practices, and other evidence-based technologies. It ensures that individuals without reliable services or with transportation challenges can access consistent and critical care. In addition to the professional clarity, the State Board of Social Examiners has confirmed its ability to implement these changes using the existing budget. There should be no additional cost to the state or to the public in achieving a higher standard of care. By modernizing our standards of the field in social work, as well as defining the increased scope of practice, we can ensure a more efficient, competent, and qualified workforce of this important service provider for the state and the people of Maryland. So I do understand and know I've been in conversations with many of the stakeholders who have some concerns about this bill. And I can honestly say that we are working to decide the best disposition for this bill at this point, but we wanted to bring it to the attention that we do need to continue focus on how we modernize our scope of practice, or not scope of practice, but our standards of practice. Thank you very much, Madam Chair. Thank you for committee for your consideration.
Thank you, Madam Vice Chair. And your panel has just arrived, so if you want to catch your breath and approach the table, and you can begin your testimony when you're ready.
It's because I was down in Judiciary. She had time to get here.
And we planned on matching. I'm Ann Seacott. They're pretty good. Testifying on behalf of the National Association of Social Workers, the Maryland chapter. We are absolutely in support of working on updating the code, the practice code for social workers at all levels. And we think it just needs the time to make sure we do it right, to make sure we don't leave anything out, to make sure cross-references and code all match. It can be kind of complicated because it is a little messy. So we'll try to make it less messy during the interim and bring you back a final product next year.
Thank you very much for your testimony. Are there any questions from the members for this panel? Seeing none, thank you very much for your testimony. This does conclude the hearing on House Bill 1119. And thank you for coming in, testifying, and then getting back out. This is a day about being flexible. I did see Delegate Kerr just came in, so we're going to go ahead and go to your bill, Delegate, which is House Bill 1150. This is health occupations, pharmacists, minor conditions, and HIV prevention and treatment. Delegate Kerr, if you would like to approach the table and bring your panel, and you can begin your testimony when you're ready.
Anyone else on the panel? Is Sarah?
Sarah's, yes.
Okay.
And then we have two people as well.
Okay.
If they can count as panelists.
Good afternoon, Chair Bagnall and Vice Chair Cullison and members of the committee, and Lindsay. I am Delegate Ken Kerr. I'm here with House Bill 115, Health Occupations, Pharmacists, Minor Conditions, and HIV Prevention and Treatment. So, approximately 14 of Maryland's 24 counties are identified by the federal government as health professional shortage areas. Another 8 are considered partially health provider shortage areas, meaning that 22 of the 24 counties in the state are affected by provider shortages. The fact is, Maryland does not have enough primary care physicians so that everyone in the state has access to primary care. So many Maryland counties have appointment delays exceeding weeks. Emergency room times, I don't have to tell this committee, in Maryland are the worst in the nation. Our primary care shortages are real, Turning to pharmacists for the care of minor conditions is one of the fastest, most effective, most expedient ways to responsibly expand capacity without building new clinics or significantly increasing state spending. So Maryland can take lessons learned from more than 30 states that authorize pharmacists to utilize point-of-care tests to diagnose minor conditions and dispense medications. And these are done by formulary protocols. You diagnose the condition, there's a first-line protocol that you follow, and whether you're in a pharmacy, an urgent care center, an emergency department, or a primary care physician's office, that protocol will be followed. Evidence reviews, international evaluations demonstrate pharmacists prescribing for minor ailments and pharmacy-based test and treat programs provide safe, clinically appropriate care without increased adverse outcomes. You're going to hear from the opposition that the pharmacists are not trained to identify comorbidities or underlying conditions. But you'll see in this legislation that if there is a comorbidity, if there is an underlying condition, then it's not appropriate for the patient to continue with treatment at the pharmacy, and they will be directed to an urgent care center or another healthcare professional. So I think it's probably best I turn it over to my panel to provide additional information here. I thank you for paying attention to this bill and for your continued care about patient care and healthcare accessibility in the state of Maryland. Thank you.
Hi, good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association, and I'm also here representing the Maryland Pharmacy Coalition. We are here in support of House Bill 1150. As Delegate Kerr mentioned, 22 of 24 Maryland counties are fully or partially designated as health professional shortage areas. Empowering pharmacists is one of the fastest ways to responsibly expand and extend treatment capacity in communities with limited access to care. More than 30 states, I want to emphasize that, more than 30 states authorize pharmacists to utilize point-of-care tests to diagnose minor conditions and dispense medication for treatment, including surrounding states of West Virginia, Virginia, DC, and Delaware. We cannot pretend, as the opponents will say, that pharmacists can't do this. They are, and they have been. Evidence reviews show pharmacy-based test and treat programs provide safe, clinically appropriate care without increased adverse outcomes. There are 375 pharmacies in Maryland that currently hold CLIA waivers, and these are the CLIA waive tests are the tests that we're talking about. So this is not a novel concept in terms of using the equipment. The goal is to enable pharmacists to fully use the tools they already have to improve patient care. And I also want to mention that the bill also proposes pharmacist-based HIV testing and dispensing of HIV PrEP and PEP, and they are reflective of evidence-based strategies for prevention. CDC clinical guidance clearly outlines protocols for screening, testing, and follow-up, and the Department of Health protocols will ensure appropriate referral and continuity of care. My written testimony provides responses based on peer-reviewed research and studies with more than 40 citations that refute the opposing testimony concerns related to training, test and treat services, diagnostic integrity, public support, interest, accessibility, the pharmacist's interest and capacity, follow-up care, and patient privacy. We have worked with stakeholders and bill sponsors to make substantial amendments to narrow the focus and address some of the concerns. We are deeply committed to patient care and community health and urge a favorable report on House Bill 1150. And I'm happy to answer any questions. Thank you.
Good afternoon, Madam Chair and honorable committee members. Sarah Price here on behalf of the Maryland Association of Chain Drugstores, also in strong support of the passage of this legislation. We are fully confident that pharmacists can provide these services. We know that the majority of jurisdictions in Maryland would strongly benefit from increased access to healthcare, to points of access for healthcare. And we believe that the amendments that have been made based on the discussion over in the Senate will completely address any concerns regarding pharmacist making diagnoses versus reading the results of a diagnostic test. We know that the training is in place. We know that pharmacists can do this. As has been noted, it's in place in many places across the country already, and we do believe that this would have a positive impact on public health in Maryland. So we would urge a favorable report. Thank you.
Thank you for your testimony. Delegate, I do have two virtual favorable witnesses. Are they part of your panel?
They're not part of the sponsor panel.
Okay, so we'll bring them up on the favorable panel. So thank you. I will open this up for questions. Any questions from the members? Vice Chair Cullison.
Thank you, Madam Chair. I'm curious about the testing. What kinds of testing would you be prescribing? And are there facilities on site of the pharmacy to complete the testing? You know, I'm thinking, I think strep throat was one, urinary tract infection. I'm thinking, is that possible in a pharmacy setting?
Ms. Horton, probably best to answer.
Yes. It's possible in the pharmacy setting. These are CLIA-waived tests. So CLIA-waived tests are considered low risk. They have high specificity, and they're protocol-driven. They have referrals, requirements, and red flags. 375 pharmacies currently have the diagnostic equipment, the testing equipment in their pharmacies. As you may know, if you go into a pharmacy, there are pharmacies that have separate spaces for patient counseling, for vaccinations, and that is accessible. I was just thinking about the next panel. One of the pharmacists can really talk about that as well. But as we expand more capacity for pharmacists to do these types of things, we'll begin to see more and more changes. But change is not going to take place unless there's ability to do the work.
Yes, you do. Okay. Thank you very much. Thanks.
Seeing no further questions, I just want to say, first of all, thank you for this document. It is really helpful. And Ms. Price, you had spoken to that you were working through amendments or delegate, whoever is best to answer, in the Senate. Do they address some of the concerns that were raised by the Department of Health?
I can speak to that too. Yeah, so they largely take in all of the request for amendment from the Board of Pharmacy. There was one where we spoke with them and negotiated the response, and I believe those amendments have been submitted.
Thank you very much. Thank you for your testimony. We do have a favorable virtual panel, and then we do have an unfavorable. So let me start with Richard Debonetto, I almost had it, and Christine Lee. Mr. Debonetto, if you want to unmute and begin your testimony. And if you want to go ahead and begin your testimony.
I'm sorry, who is this for?
Dr. Debonetto.
Hi, I'm Rich DeBenedetto. Thank you for having me here. I'm here to tell you that pharmacy students have been taught and are continuing to be taught and provide point-of-care testing. They demonstrated their value in 2020 when we needed a massive host of people to provide testing services. Pharmacists are trained and available to provide care, and they've been demonstrating this in areas like vaccination, test and treat services for COVID, as well as the multitude of other health screening and monitoring modalities that we see, things like blood pressure, glucose testing, lipid testing. Pharmacists are known as the most accessible healthcare providers. There's typically a pharmacist within 5 miles of every patient. Whereas we know, specifically on the Eastern Shore where I live, there's really only 2 providers in the state of Maryland on the shore that provide HIV treatment services, and one just across the border in Delaware. Here's where we need pharmacists. To end the HIV epidemic program is looking to reduce new infections and end the problem that is overwhelmingly borne by minority and marginalized communities. Over 1.2 million people in the country are currently at high risk for acquiring HIV. PrEP utilization rates are underwhelming in spite of the promotional materials showing beautiful people that we need to be using it. Primary care providers don't prescribe PEP or PrEP. Whether they don't think about it, don't think it's their role, don't feel comfortable with it is unknown, but they aren't providing it. This leaves HIV treatment providers to provide the service, and there simply aren't enough treatment providers to reach all these who need these prevention services, and patients aren't seeking that specific care service. With the advent of the ability to test for HIV in the pharmacies afforded by this bill, the pharmacist could test for infection, provide counseling on risk reduction methods, provide PEP or PrEP services for these patients when appropriate, and provide linkage to care for a provider who can provide ongoing medical care, including HIV prevention. PrEP works. Long-acting medications work. Combining them has worked, and those products are not being covered. This requirement for coverage for at least one drug, I'm letting you know about the previous testimony that we heard.
Can you wrap up your testimony, please?
As covering only the generic Truvada, and that's a drug that we know is somewhat toxic. Thank you.
Thank you for your testimony. And if you can stay on in case there are questions from the members. Christine Lee, if you want to go ahead and unmute and begin your testimony.
Sure. Thank you, Madam Chair and committee members. Thanks for allowing me the opportunity to speak favorably on House Bill 1150. So I am one of the 375 pharmacists in the state of Maryland that have a CLIA waiver. I own an independent pharmacy in Baltimore County. We do specialize in assisted living facilities, mental health facilities, substance use facilities, and I have taken full advantage of other legislation that has been passed through this committee, notably birth control prescribing and also long-acting injectables. So when Aaliyah asked me to present today, I said a resounding yes. Pharmacists are able and capable of doing point of care testing. It's actually disappointing that it has taken this long to get to this point. As has already been mentioned, 30 other states are already doing this. During COVID, my team had tested over hundreds and hundreds of patients for COVID, and I have colleagues that have done thousands of these tests. So when we're talking about tests, we're talking about simple tests. There's many people sitting listening to this testimony. There's many people on the committee that have done these tests themselves. So can a pharmacist do the test? Yes, a pharmacist can do the test. Can they read the test? Yes, the pharmacist can read the test. There's no question whether or not that this is something in my wheelhouse. So I want to just take a minute to say that. And then in terms of accessibility, I am also a business owner. I have 15 employees under me. Any day of the week, somebody tells me they went to urgent care, they went to the emergency room, they had they thought they had the flu, that they thought they had strep throat, they have a child that's sick. And I say, why didn't you go to the doctor? Which would be like the right answer. And the right answer is not always the realistic answer. The realistic answer is, they weren't necessarily available. Pharmacists available, they're willing, and they're capable of doing these tests. So if you have any questions, I'd be more than happy to answer them for you. Thank you and have a great day.
Thank you for your testimony. I'm going to open it up for questions from the members. Are there any questions for this panel? Seeing none, thank you very much for your testimony today. We do have one unfavorable panel. So if I can bring Steve Wise, Christine Saba, and we have one virtual Laura Bogley. Is he virtual? Oh, okay. Let the record reflect that Steve Wise is not available. Christine Saba, if you want to begin your testimony.
Can you hear me? Okay. Good afternoon, Madam Chairman and members of the committee. My name is Dr. Christine Saba. I'm a member of MedChi and a board-certified pediatrician practicing in Rockville, Maryland, with more than 25 years of clinical experience. Earlier in my career, I was the first senior clinical pharmacist in the pediatric intensive care unit at Johns Hopkins Hospital, working within the physician-led team caring for critically ill children. From the perspective of patient safety, I'm here today in opposition to House Bill 1150. Symptoms that appear minor still require comprehensive, careful medical evaluation. Dr. Suzanne Martin, an ER pediatric physician, testified before the Senate about a kindergartner with painful urination that appeared to be a urinary tract infection. Instead, a comprehensive evaluation revealed genital herpes due to sexual abuse, a diagnosis that would have been missed without proper medical examination and testing. In my practice, for patients with cough and breathing difficulty is very common in caring for them. In severe asthma, the airways can become so constricted that very little air exchange is and no wheeze is heard. Patients have to be told their lungs are clear and have been told that when in fact their airways are so tight they cannot create enough movement air to create a wheeze. This rapidly progresses to respiratory exhaustion and death. Another case was a 6-month-old infant was brought to me with persistent crying, which could have been attributed to constipation. After my history and examination, I referred the patient to the emergency department for evaluation of possible abdominal mass. He was diagnosed with neuroblastoma, a pediatric cancer. Detected early, that child was cured and is now thriving. While increasing access to medical care is a laudable goal, providing urgent access cannot come at the expense of incomplete and comprehensive diagnostic evaluation. Having practiced earlier in my career as a clinical pharmacist in the PICU at Johns Hopkins, I will be the first to say pharmacists are invaluable members of the healthcare team. I have one sentence to finish. May I complete? Thank you. I will also be the first to say that diagnosing illness can be complex and requires the training physicians receive through medical school and years of residency. For these reasons, I respectfully urge the committee to oppose House Bill 1150 in the interest of patient safety for the citizens of Maryland.
Thank you for your testimony. And we have one more unfavorable witness, and then we'll open it up for questions. Ms. Bogley, if you would like to unmute and give your testimony.
Thank you, Madam Chair, members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life. We ask you to put patient health and safety before profits by amending this bill for safety or giving it an unfavorable report. Pregnancy is not a minor condition. Women in Maryland deserve quality prenatal and maternal health care. But this bill would make pharmacists abortion providers, allowing them to directly prescribe lethal abortion drugs without a doctor's examination or any other patient safeguards. With the proliferation of lethal abortion drugs, which now account for nearly 3/4 of abortions in the U.S., the state of Maryland has a duty to ensure that chemical abortion is safe. New research reveals that chemical abortions are 4 times more dangerous than even surgical abortions, and at least 11% of women experience serious complications from abortion pills. With the approval of abortion pills, the demand on emergency room personnel to deal with serious abortion complications has increased by 500%. Increasing medical scarcity and threatening the conscious rights of medical providers. This is a government-engineered health crisis. But by asking pharmacists to prescribe these drugs without oversight by a physician, the state will be putting women's lives at risk. For example, underestimation of gestational age may result in a higher likelihood of failed abortion, which becomes a medical emergency that could be fatal. Undetected ectopic pregnancies may rupture, leading to life-threatening hemorrhages. There also is the risk of abortion coercion and forced ingestion. There are incidents from across the nation we're hearing of men and others ordering these abortion drugs without oversight and administering them to women without their knowledge or consent, causing unwanted abortions and traumatizing these women. Catastrophic complications also can occur through teleabortion and even school telehealth, and emergency care may not be readily available in remote or underserved areas. We must put patients before politics, and for these reasons, we urge your amendment to exclude abortion by pharmacists or your unfavorable report. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Delegate Hill.
Thank you, Madam Chair, and I apologize for having missed the first part of the hearing because I was in another committee. Doctor, I'm reading some of the testimony for the proponents, and they point out that there's evidence that pharmacists can, in other states, be authorized to utilize point-of-care tests to diagnose minor conditions and dispense medications. I know we passed legislation in Maryland for birth control with some caveats of what they have to do, and mostly that was because the OBGYN said that birth control really should be over-the-counter, not prescriptive. Do you think of HIV prophylaxis as a minor intervention, or can you express what your specific concerns about?
Sure. Thank you so much for asking that. I think when we think about, it's these algorithms or the way medicine has sort of evolved, we're putting things in minor categories. To me, HIV prevention is very important. It has multiple preventions. We certainly don't want someone getting HIV. As a pediatrician, I address this with my pediatric patients, adolescents. I'm very open. It is my duty to care for the patient despite what their choices are. I'm there to support their health. I query, we ask, we're taught for adolescents, we are to ask what are their preferences. It is our duty and responsibility to screen. The Academy of Pediatrics, once we know someone is sexually active, we are to screen them for HIV, as other STDs. I have very open conversations with my adolescents. I prescribe PrEP. There's follow-up that needs to happen with the patients. My concern is that if they just walk in a pharmacy because of whatever reason, there's multiple fold, and I'm not saying patients don't get shamed. I've been shamed, for other reasons. So, we're all human beings and people can pick up things. My concern is who's gonna follow up, right? If it's an adolescent who's like, okay, I'm about to have anal sex, I need to get PrEP, they go in there. So you do a point of care, there's always a false amount of positive, false negative. Who's gonna follow up with that adolescent? Who are they gonna go to next to get the next dose? They're gonna go to another pharmacy. Like, where's the follow-up? This is the concern. This isn't we need to give access, but we need to come up with creative ways that protect patient safety. So to me, it's not a minor diagnosis here. HIV is life-threatening if we don't diagnose appropriately or follow the patient appropriately. These medications need to have liver enzymes followed also. So, I have concerns on many, many levels. And having practiced as a senior clinical pharmacist, I always viewed it as a wonderful way to collaborate team-wise. I rely on my pharmacist. I call them. I can't keep up with all the newest things and then pharmacodynamics and everything. We're team here. This isn't about, it's about patient care. And that's where I know I'm coming from, and I know that's where my medical society has always come from. And the increasing scope, I don't want to include too many other things, but I will say this. I have, for the past 15 years, as a pediatrician, collaborated with pediatric psychiatrists once a month during September through the school year. We bring in pediatric psychiatrist experts to help us deal with patients with anxiety, depression, help us learn better about the medications and when to prescribe to help clinically diagnose. I, with my background and all that, am able to engage in this kind of a direction because having to have access more for the adolescent patient to get treated, or even the young adults for the increased depression, anxiety that's going on. And to see a bill now being proposed for psychologists to be able to prescribe psychiatric medications is concerning to me.
I'm going to ask that we stay on this bill.
Right, so, but
because we
regarding
have a
minor
number
conditions.
of bills today. We still have a number of hearings. Thank you.
HIV prophylaxis is needed because HIV is not a minor condition. It can be life-threatening.
I have just one follow-up. You spoke to collaboration with
Yes, ma'am.
pharmacists. And so the question is, and you said that one of the reasons you collaborate is because they are much more up-to-date in the latest medications, and as you focus on clinical issues and treatments, they really are experts on the medications. Do you find that that collaboration is both ways, that you have information about clinical diagnosis and other things that are not related to pharmacology, that in the collaboration you're educating them about as well, so that they don't know everything about clinical diagnoses?
Clinical diagnosis comes from many years of clinically examining patients, right? So it's a built-in process. So, you know, if I need to call the pharmacist to ask about the extended release or check something, I'm usually calling the hospital pharmacist or drug information at Hopkins to get further literature to help me decide something in a particular clinical situation for my patient. So that's where I go for certain expertise. You know, basically, like, the reason we send our patients to a GI specialist, because I'm not the one that's the expert in all those medications at this point, right? Or sending my patient to a cardiologist for their ablation for arrhythmia, and pre that, they're on their antiarrhythmic medications. I'm not going to say I'm the expert in that. So there's varying degrees about where and how we go and what we need to do.
All right, thank you. Thank you.
Does that help?
Yep.
I just want to clarify, because I think this conversation has perhaps convoluted a little bit, because in the bill on page 3, it says on line 27, do not require a new diagnosis.
I'm sorry, pardon me?
So this is not a question for you.
Oh, okay.
I just want to clarify, because we were getting into diagnosis and treatment, and I want to make sure that we're keeping the conversation on the bill that we're considering. So thank you very much for your testimony. Seeing no further questions, this does conclude the bill hearing on House Bill 1150. I'm certain that our bill sponsor will continue to work with our committee, and we are going to move to House Bill 1136. Delegate Jones has entered the chat. So this is nonprofit hospitals, community benefits. And Delegate Jones, if you want to come to the table, bring your panel, and you can begin your testimony when you're ready.
All right, panel. Come on up, folks. And we have some more chairs. Here, let's do this.
And for the, for planning purposes, for the committee, we have 7 more bills in this hearing.
Thank you so much. For the record, I'm Delegate Dana Jones, representing District 30A in the House of Delegates. Chair Bagnall, Vice Chair Cullison, and members of the Health Committee, I'm here today to introduce HB 1136, Nonprofit Hospitals, Community Benefits. The purpose of this legislation is to provide additional clarity and transparency on the exact sum and beneficiaries of the community benefits that Maryland's nonprofit hospitals are providing in communities around our state. I'm introducing this legislation alongside a package of amendments that are the product of extensive conversations I've had with stakeholders. And let me take a second to say thank you to the Comptroller's Office, the HSCRC, the Maryland Hospital Association, SEIU 1199, and others for their engagement on this legislation. Our conversations have been wonderful, and I appreciate them. The amendments address the Comptroller's comments and have significantly addressed the comments received from the HSCRC. It was really vital to me to hear from as many stakeholders as possible, even where there were natural disagreements, right? I also want to thank the members of this committee and stakeholders around Maryland who have done significant work to improve reporting on hospital community benefits in recent years. In many ways, Maryland is a leader. However, I believe there is significant room for improvement. I'm introducing this bill for a few simple reasons: transparency, accessibility, and affordability. Although the HSCRC does great work collecting and reporting hospital community benefits, there are still some gaps and a need for additional clarity. Hospitals do not estimate the value of their tax exemptions. This makes it impossible for the public to reasonably compare the benefits provided against the value of exemptions received. There are no minimum requirements and no benchmarks tied to tax exemption value. Additionally, as mandated by federal law, hospitals produce community health needs assessments every 3 years and provide them to the HSCRC. These reports are designed to identify health needs and develop strategies to address them. However, according to FY24 HSCRC report, only 42.5% of net community benefits are spent on CHNA activities. There's also a wide range of spending on CHNAs activities, with the top hospital spending 97.4% of total community benefit expenditures on CHNA activities. The lowest hospital spent less than 1% of their community benefit implementing the community health plan they are legally required to develop with community input. Lastly, there's significant ambiguity. I have a cough drop in my mouth, and it is really setting me back, but helping the cough. On what the CHNA spend actually goes, with the largest single category vaguely labeled settings and system community. This is just one example of the nature of community benefit spending by Maryland nonprofit hospitals. As I mentioned before, I'm extremely grateful to the HSCRC and to the individual hospitals for their existing reporting work. However, it's imperative that we know exactly where these benefits are going, exactly how they are helping our communities, and exactly how much each hospital should be spending compared to the value of their tax exemption. Finally, the comptroller has advised my office, with the amendments that I have also submitted, the comptroller's office can implement this legislation with existing resources. I look forward to having additional dialogue with the committee on this, as well as continuing the conversation with all of the advocates. With that, I respectfully request a favorable report on HB 1136.
Chair Bagnell, Vice Chair Cullison, members of the Health Committee. I'm Jamie Gregory, here representing Consumer Action for a Strong Economy. As mentioned, nonprofit hospitals in Maryland enjoy significant public benefits. In return, they are expected to deliver charity care and community benefits that justify those privileges. According to the Loan Institute, 18% of Maryland's nonprofit hospitals do not give back as much as they receive. In Maryland, nonprofit hospitals receive approximately $587 million annually in tax benefits, which include local property tax exemptions, state sales tax exemptions, state income tax exemptions, federal income tax benefits, and access to tax-exempt bond financing. During the 2020 session, this body passed legislation, adopted legislation requiring the Health Services Cost Review Commission to establish a community benefit reporting work group. The enacted work group recommendations require nonprofit hospitals to provide an annual community benefits report, which is available on the commission website. This reporting is a good first step, but much more can be done. HB 1136 would establish measurable performance thresholds for the state tax exemption. Nonprofit hospitals would be required to provide community benefit equal to either 100% of the value of tax benefits received or 5% of net patient revenue, with at least 4% devoted to charity care. The bill will strengthen the nonprofit hospital social contract by aligning public subsidy with public return. Now I'd like to introduce Peter Pitts, President of the Center for Medicine in the Public Interest, and he is a former Associate Commissioner of the U.S. Food and Drug Administration.
Thank you. Thank you, Madam Chair, members of the committee. Yes, I'm a former federal official here to help, so I apologize for that. Nonprofit hospitals in Maryland contribute to rising healthcare costs through practices that prioritize financial gain over community benefits, revealing systemic issues such as high pricing, lack of transparency, and political lobbying. Though nonprofit hospitals in Maryland receive millions in taxpayer-funded subsidies and donations, many fail to meet expectations for providing affordable care and meaningful community benefits. These hospitals function like for-profit entities, despite their tax-exempt status and public funding sources. In Maryland, not-for-profit hospitals increasingly avoid Medicaid and uninsured patients due to lower reimbursement rates, focusing instead on services provided that favor private insurers, leading to inequities in care. Maryland's nonprofit hospitals, like many nationwide, face criticism for prioritizing profits, aggressively suing poor patients, and failing to provide community benefits commensurate with their tax exemptions. Consider aggressive debt collection. Nonprofit hospitals in Maryland have been documented suing low-income patients for unpaid medical bills, sometimes leading to wage garnishments or liens, despite patients potentially qualifying for free care. Lack of standardized oversight. According to Johns Hopkins, there's a lack of clear federal or state mandates linking community benefit spending to tax exemption, leading to wide variations in what hospitals provide and loopholes for some to benefit without adequate contribution. Financial practices. Some reports indicate significant profits and high spending on executive pay, new buildings, and acquisitions rather than patient-focused care, leading to concerns about where the nonprofit money goes. I've got much more to say. I look forward to your questions, and thank you for the opportunity.
I believe, is this your entire panel, Delegate Jones?
No, actually. Oh. Yes. Yes. It's full sponsor panel.
Okay, great, thank you.
There are others who are signed up, Vice Chair.
Yes.
Yeah.
And we will hear them. Thank you, Delegate. Let me go to questions. Delegate Hutchinson.
Thank you, Madam Chair. Thank you, Delegate. I see sort of here in the fiscal note, if so the hospital doesn't comply in this, they would potentially lose their nonprofit status, their tax exempt status. Yet we just passed a bill out of the House the other day that all hospitals in the state of Maryland have to be nonprofit. So what would happen there?
Do you want to go there? Yeah. The bad behavior of not-for-profit hospitals would grow if there are more, when there are more not-for-profit hospitals, which makes oversight so key. You know, if you're, and I support that notion that all hospitals should be nonprofit hospitals, but it doesn't mean the problem goes away. In fact, it may very well mean that the problem grows. So, you know, really further aggressive oversight onto how not-for-profit hospitals address community service and how they spend their monies becomes even more crucial.
But the question really is then what happens to that hospital? They've lost their nonprofit status, and we can't have anything other than nonprofit hospitals in the state of Maryland.
So Delegate, I think that's a mechanism for accountability. And you're raising a valid point. Obviously, the goal is never to get to that step.
Thank you.
Thank you.
Delegate Hill.
Okay, thank you, Madam Chair. Thank you, Delegate, for the bill. I'm trying to wrap my head around it, so I hope this question doesn't seem dumb. In the provisions, and this is for, you know, whichever one of your panelists can best, as you talk about that the community benefits, so it sort of sets a standard, has to be either at least 100% of the value of the hospital's tax exempt benefits, I understand that, or equal at least to 5% of the value of the hospital's net patient revenue if the value of all charity care provided equals at least 4% of the value of the hospital's net patient revenue. Where did that 5% and 4, are those numbers linked to something? Why are those the numbers that you're using? And what are we getting at here?
Do you want to do that, Peter? I guess the question becomes what should be mandated for a not-for-profit hospital to return to the community in terms of benefit? How do you measure benefit? You know, clearly not everything a not-for-profit hospital does and offers to the community falls into that category. Sponsoring Little League teams, for example, I don't think should fall into that category. I think it requires flexibility. I think that part of the problem now is that there are a lot of games being played relative to reporting what return to the community means. And whether it's 5%, whether it's 50%, whether it's 100% is up for discussion, which is why the next step, should this piece of legislation pass, is to make sure everybody comes to the table and is honest. The nomenclature, the reporting standards, there's a difference between a big report with lots of words in it and a report that actually has substance to it. And I think that's really the key issue.
And Delegate, I think the 5% of net revenue is there as an achievable goal.
So it's arbitrary. It was just a number that you came up with an alternative to saying 100% of the value of the taxes and benefits, which I can understand. You got this much in taxes, we want to know that your community benefits of that. But this alternative was just an alternative, and 5% felt like the right number?
Yeah,
It's
an
not based
achievable
on
number.
anything. Okay, that's, all right, thank you.
A low achievable.
Yeah.
Yeah, Delegate Wright, thank you. Just trying to wrap my head again, kind of, similar to some of the questions we've already had, like what item would be sufficient to be a community charitable product? Like, for instance, I can give you an example for, one of our hospitals. Would, like $3 million a year to keep our behavioral health center or facility in operation, would that be something that would qualify as a community charitable event?
I think that's a very smart question, because what we're looking at isn't really so much, the dollar figure, so much as what is a community benefit. Should a community benefit be promotion of, television promotion of the hospital? Should paying for lobbyists in Annapolis count towards community benefit, because today that it does? Or should the earmark for community benefit really tied to specific community benefits, as a common sense person might define that?
Okay, so, and follow up, I'm sorry, Madam Chair. So, so I think this is, a good cause, and I think it would fall under, this would be something good that would follow and say, hey, yes, they're being good stewards in the community. But on the other hand, this is, stopping them from doing other things and infrastructure of equipment, because we, as a state, are not paying to keep these behavioral health facilities open and in operation. And the hospitals, it's a shame, in my opinion, that the hospitals have to do that. Thank God we do have, other people in the community that help out with, entrepreneur monies. But, so I don't know. I just have I think I have a problem.
That's a good point. And I think it's important not to kind of throw the baby out with the bathwater. This is not to say that hospitals aren't doing good things with their community service dollars, because they are. It's a question of holding them accountable for what they're doing wrong with it. Okay. And the lack of oversight really allows a slippery slope into such behavior.
And I just want to say, before I continue with questions, that we want to make sure that we're not inadvertently maligning in our testimony with things that have not been verified. The whole point of the bill, as I understand it, is that transparency. Right. So I just want us to be thoughtful in how we are framing this discussion. Vice Chair Cullison.
Madam Chair, Delegate, have you had a chance to read the HSCRC letter, and have you had conversations with them?
We did have conversations with them.
So in terms of their concerns around not being duplicative, meeting the timelines, meeting the requirements of the AHEAD model reporting, do you have some ideas about how to address some of those concerns in the bill?
In my conversations with the HSCRC, those are really, that's where, let me just also say, as a reminder, that's where our amendments came from in order to come to an agreement at the table with stakeholders. Okay. So the amendments that are provided, hopefully you have them in your system, really reflect what they were requesting in an effort to meet halfway. Did you have anything that you wanted to say?
That's exactly that point.
For the members' awareness, they were emailed, so it's they are in your inboxes. And do we have Delegate Warman?
Thank you for the bill. And thank you, Madam Chair. Just a quick question. Are there any? I think when I was looking through, I feel like, I think I read that there's only one enforcement tool, and it is just revoking somebody's tax exempt status. Is that the only, I'm just trying to see if I missed something, if there's any other intermediate steps before we go to revoking.
There is a fine mechanism before that step.
All right, thank you.
Yeah.
All right, seeing no further questions, thank you very much for your testimony. We do have a favorable panel, so if I can bring Jennifer Baven-Dangle and Ashlyn Randolph, and then we have, Marceline White, and then we have a favorable with amendments and unfavorable. So if I can bring Jennifer Bevan-Dangle, Ashlyn Randolph, and Marceline White to the table. And
Jennifer cannot be here, I'm sorry.
Oh, okay, nope, I appreciate you letting us know. You can begin your testimony.
Good afternoon, Madam Chair, Vice Chair, members of the committee. For the record, my name is Marceline White, Executive Director of Economic Action Maryland Fund. We're here in support of House Bill 1136. We received the amendments today, so I haven't had a lot of chance, but I'd love to talk a little bit about them. We believe this builds on the strong bipartisan work of this committee around medical debt and around expanding financial assistance policies and expanding financial assistance. Just to be clear, all hospitals in Maryland are nonprofit hospitals right now. And under the Affordable Care Act, hospitals get a tax break, and to do so, they have to provide community benefits. What this bill at its core says is that the hospital community benefits should at least equal their tax breaks. That's what the bill says, and it requires reporting in order to do that. If hospitals choose not to meet the community benefit standard that's equal to the tax break, they can forfeit the tax break. I do want to note there is an $82 million deficit right now in Maryland. That represents funds that communities need and could be used to expand charity care or address social determinants of health. And that deficit is hospitals that are getting more in tax breaks than they spend in community benefits. We believe this does increase transparency. We believe it will build public trust between communities and hospitals with the reporting clarifying what constitutes community benefits right now, and it meets hospitals' legal requirements under the ACA to provide these benefits. Hospitals should be able to meet these requirements because this is a condition of their nonprofit status and of their tax breaks, and it has been so for years. So we support HB 1136. Again, haven't looked at all the amendments, but have some concerns and would urge a report, favorable report.
Hello, good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. Thank you for the opportunity to testify. My name is Ashlyn Randolph, and I'm here on behalf of the League of Life and Health Insurers of Maryland. I'm sorry about that. My name is Ashlyn Randolph, and I'm here on behalf of the League of Life and Health Insurers of Maryland in support of HB 1136. Every hospital in Maryland operates as a nonprofit, and in exchange for that status and the tax benefits that come with, hospitals are expected to invest in their communities. Maryland has always given hospitals broad flexibility to determine how best to meet that obligation, whether through charity care, behavioral health services, housing programs, or other initiatives aligned with their institutional mission. What has been lacking is sufficient oversight to ensure those dollars are actually spent as intended and not redirected. This bill addresses that gap. It establishes a clear spending floor, requires itemized and transparent reporting, and creates an accountability mechanism for hospitals that fall short. It does not tell hospitals how to spend their community benefit dollars. It simply requires that they actually do so and that they demonstrate it. Maryland's all-payer model works because every participant is held to a defined standard. Insurers are subject to rigorous requirements under that model, and it is only reasonable that nonprofit hospitals be held to theirs as well. When community benefit dollars are spent as intended, the result is healthier communities, and healthier communities mean better health outcomes for every insured person in the state. The standard already exists. HB 1136 just ensures that it is enforced. The League urges a favorable report, and we thank the committee for its consideration.
Thank you for your testimony. I'm going to go ahead and open it up to the members for questions. Vice Chair Cullison.
Thank you, Madam Chair. Marceline, you kind of referenced, when you were going through the amendments that you had some concerns. Yeah. Can you speak more about that?
Absolutely. I mean, I received them today, so I'd like to take them back to our coalition of consumer advocates and patient advocates to vet them more fully. But one of the things that I noticed is there's a change in the language around hospitals have to willfully demonstrate that they did not meet the community benefit standard. And I have a concern for how that would play out, because I think it would be very easy for, it would basically reduce any teeth in the bill. It's a pretty high standard to show that you willfully did not provide the benefits. And so I do have concerns around that. And again, this is something that since they've got nonprofit status under the AAC, they've known about and they've been supposed to comply with. So I think willfully is just too high a standard, and they comply or they don't comply. But again, I want to take it back to the whole coalition because we haven't really had time to vet them.
Okay, great, thank you.
Seeing no further questions, thank you for your testimony. We do have a favorable with amendment. That's Lorraine Ericott. If you want to come to the table and go ahead and give your testimony.
Good afternoon, Chair and members of the committee. My name is Lorraine Aricot. I'm the Senior Policy Analyst with 1199 SCIU. We represent healthcare workers across the care continuum in hospitals and long-term care settings. 1199 supports holding tax-exempt hospitals accountable to their charitable mission in order to meaningfully improve public health, particularly for communities who experience health inequities in their neighborhoods. We support HB 1136 with some friendly amendments to strengthen the bill. Throughout all nonprofit hospitals in Maryland, only 42.5% of community benefits go towards priorities identified by the mandatory community health needs assessment. As stipulated by the Affordable Care Act, hospitals are required to conduct these community health needs assessment every 3 years and implement an implementation strategy. Our amendment to this bill would ensure that 80 to 100% of a hospital's community benefits spending meets those identified priorities, especially if a hospital's tax-exempt status depends on their contribution to community health. We have also been looking at community health benefit reporting submitted to the HSCRC and have worked with the HSCRC to improve how community benefits is calculated. And there's 3 gaps that still need to be addressed. Hospitals are still not reporting the value of their tax exemption. Therefore, it's very hard for the public to determine whether their charitable work is commensurate to the value of their tax exemptions. 2, current reporting does not clearly demonstrate how much of a hospital's community benefit spending directly supports programming and initiatives that improve population health outcomes. And 3, it's clear that hospitals are not adequately engaging communities in their development of those community health needs assessment. So we thank sponsors for bringing this bill forward and for the opportunity to have a critical discussion at the state level on improving transparency and oversight of community benefits, and look forward to working with the sponsor on these amendments. Thank you.
Thank you for your testimony. Are there any questions for this witness from the members? Seeing none, thank you very much for your testimony. We do have one unfavorable. We have Jane Cranky. You want to come to the table and begin your testimony when you're ready.
Thank you, Madam Chair. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. My name is Jane Crinky. I'm here on behalf of the Maryland Hospital Association in respectful opposition to House Bill 1136. We appreciate the sponsor, Delegate Jones, bringing this bill, the intent of this bill. We agree that hospitals should provide publicly accessible reports and around their community benefits, and in fact they do. You can right now go to the HSCRC's website, see the aggregate report, pull up individual hospital reports, both the narrative and the financials. As you know and have heard, each year nonprofit hospitals have to complete the Schedule H of the IRS Form 990 and put that on the website as well. And I just wanted to flag one unique thing about Maryland is that we're one of 11 states that have tied our community health needs assessment to the community benefit reporting. That was a result of that 2020 work group that you all heard about, thanks to this legislature passing legislation to create that stakeholder group. I want to point, as the Vice Chair mentioned, to the HSCRC's letter, because I think their concerns are valid. And I do want to note we haven't seen the amendments, so we're responding to the bill as introduced. But in the HSCRC's testimony, they note 3 challenges around charity care. So if a hospital's financial assistance policy now is more generous than required by law, that additional assistance can be claimed as a community benefit, the proposed bill would remove that flexibility. In regard to the tax exemption value, back in 2020, HSCRC did conduct a tax benefit assessment and asked the question, should we require this for hospitals to demonstrate that that they're matching their tax exempt value. And the consultant that did the study said it was possible, but it'd be incredibly challenging and complicated and time consuming. And it lists a number of factors why. So just wanted to point that is linked in their testimony. And the reporting requirements and timelines, HSCRC notes that they conflict with the newly revised regulations. They reduce the flexibility needed to ensure comprehensive and accurate reporting, and they could be duplicative. There's a lot of concerns with this bill, and I know we are very transparent. Hospitals invested more than $2 billion in total community benefit in FY24. We're very proud of this and happy to keep engaging in conversations, but just wanted to note the value that we have. The process we have now is very effective and transparent. So we ask for an unfavorable report.
Thank you for your testimony. I'm going to open it up for questions from the members, starting with Delegate Hutchinson.
Thank you, Madam Chair. Jane, nice to see you here today. And I just was looking at your letter, and it is quite impressive. So $2.35 billion in total community benefits in 2024, up from $1.75 billion from 2019. So I see that as a very impressive number of what our hospitals are providing back. If this bill were to move forward, could it have a negative effect in terms of quality of care, patient access, potential hospital closure, anything that could be detrimental to the great hospitals that we have here in the state of Maryland?
Sure. Thank you so much for your question, Delegate. Hospitals are very proud of those investments, and again, they're tied to the community health needs assessment. If we're concerned if we put any type of floor or ceiling on this could impact what hospitals are doing around community benefit. I know the chair had a bill last year on community health workers, which we included with flexibility just to make sure we didn't have the opposite impact. And so I think allowing hospitals the flexibility to use their community benefits to serve their community is really important, and putting arbitrary numbers around how much or how little could have the opposite effect. And hospitals, especially as this committee knows best, is entering into the AHEAD model where we need as much flexibility, and we have a number of benchmarks that are making us focus on population health outcomes and metrics. And we have a lot on our plate right now, and it would be concerning if anything would push us in the opposite direction, since we are making impressive investments now.
Thank you. Thank you, Madam Chair.
Delegate Hill.
Thank you. Where can we get the numbers for, in other words, the claim for this bill is that hospitals may not be providing community benefits that match what they're getting in tax exemptions. Where can we get those numbers about, for each hospital, what their tax exemptions were and what the value of the community benefits were?
Sure. On the HSCRC website, they do have the individual reports by hospital that they submit, and those metrics were developed by the stakeholder work group, and then they have the aggregate report. They have not identified the tax exempt value per hospital to do a direct comparison, but all that other information is available on the website.
Right, so the individual is not available, and so we can't see for our local hospital what the matchup is that right?
Correct.
And it's not in their reports either, the individual hospital reports. They just say we've done charity benefits, but they don't tell what their tax exempt status benefit was.
I don't want to tell you wrong. I'd have to go back. I can ask and provide information back to this committee, because it's complicated. You have the federal and then the state. There's different levels of different taxes, so we can bring the information back to the committee if that's helpful.
That'd be helpful. Thank you.
Sure.
Thank you very much. I just want to say I appreciate that you're going to continue to work with the bill sponsor and work through these amendments, which to the sponsor's credit were in concert with the HSCRC. So it sounds like they may address some of those concerns. We also do recognize that this is a concern that has been raised previously, that those community benefit dollars maybe weren't flowing into the community as readily as we would prefer. And I know that was, in its previous incarnation, a big priority of the AHEAD model. We know that it's gone from health equity to health efficiency, which is a prioritization of those dollars. So I would ask if you could work with the bill sponsor to ensure that we are creating a framework that still aligns with the AHEAD, but also gives us the transparency so that we can understand our budgets as well.
Sure. Absolutely. Thank you, Chair.
Thank you very much. This does conclude the bill hearing on House Bill 1136. We are now going to go to House Bill 1042. This is Health Occupations, Structural Racism Training Funding Sources. Delegate Warman, if you want to approach the table and bring your panel, and you can get started with your testimony whenever you're ready.
Thank you, Madam Chair. Thank you, Vice Chair Cullison and members of the committee. For the record, I'm Delegate Teresa Warman, representing District 16, and I'm here to present House Bill 1042. This bill is really just about clarifying what this committee and the General Assembly worked on and passed last year through 2025's HB 783. HB 783 established the requirement that certain healthcare professionals receive training on implicit bias and structural racism as part of their continuing education. As the law moves into implementation, HB 1042 simply makes explicit what was always the intent, that this training be developed and offered at no cost to the state, using external funding sources such as grants, like the grant the Maryland Nurses Association received from the American Nurses Association. So this bill does not expand the mandate, it doesn't create a new program, it just clarifies that the training must be funded through outside sources rather than the state general funds. We know that this matters, especially with our fiscal situation, and if we require something, we should also have the responsibility to be clear about how it should be paid. It should be paid for. You'll hear from stakeholders and see in the testimony that the Maryland Nurses Association is one potential source of training, but not the only one, and it aligns with how continuing education typically works across different health professions. Ultimately, it's just this bill is just a clarification bill that reflects the original intent of last year's 783, and it maintains a commitment to addressing health disparities and ensures that training can be provided without burdening Maryland taxpayers. I respectfully ask for a favorable report, and we'll turn it over to my panel.
Good afternoon, Madam Chair, Vice Chair, and members of the House Health Committee. My name is Megan Goodman, and I am an intern with the National Association of Social Workers, the Maryland chapter, representing over 2,600 social workers across Maryland. We are here in support of HB 1042, and we thank Delegate Warman for leading this effort. We appreciate the General Assembly's leadership last session in passing HB 783 to strengthen implicit bias training requirements by explicitly including structural racism. Social workers, like all health professionals, are required to complete continuing education because behavioral health is constantly evolving. Ongoing training ensures we remain competent, ethical, and aligned with best practices. It provides client safety, improves outcomes, and reinforces public trust. Importantly, it also requires us to examine our own implicit bias and understand how structural racism shapes access to care, treatment decisions, and health outcomes. Our position is grounded in the NASW Code of Ethics, which calls on social workers to challenge social injustice and promote cultural competence. We firmly believe that social workers are uniquely qualified to train social workers on the ways implicit bias and structural racism show up in behavioral health settings, including diagnosis, engagement, and service delivery. We also believe nurses are uniquely qualified to train nurses, and the same for occupational therapists and all other healthcare professionals. While there is overlap, there are unique aspects to every health occupation, and our training should be by and for those with expertise in our profession. HB 1042 is necessary to clarify that other entities representing other healthcare professions are allowed to develop and deliver qualified trainings on structural racism and implicit bias. We believe the language in last year's bill was ambiguous, and this small change will make a big difference. Thank you for your time and your continued commitment to addressing health disparities in Maryland, and on behalf of social workers across Maryland, we urge a favorable report on HB 1042. Thank you.
Thank you for your testimony. Great timing. I'm going to open it up for questions from the members. Let me start with Vice Chair Cullison.
Thank you, Madam Chair. Thank you, Delegate, for this clarification. There is a recommendation for an amendment from the University of Maryland School of Social Work to add the words but not limited to, so it would be external sources such as, but not limited to the Nurses Association, et cetera.
Absolutely, I'll consider that a friendly amendment.
Thank you very much. Right.
Delegate Hutchinson.
Thank you, Madam Chair. Thank you, Delegate. I just wanted clarification because it did pull out, it specifically mentioned the grant from the Nurses Association. And so we're saying that external resources have to pay for this for the state. What if those resources aren't there anymore? There's not enough from the Nurses Association. I'm just trying to figure out the universe of opportunity to fund this.
Yeah, thank you for the question. So it's kind of how continuing education works, that it gets funded through University of Maryland, different professional organizations, not just the professional organizations, but higher education institutions that put money into continuing education. It's just part of what they do. They do the same thing for financial, CPAs and that kind of stuff. But it's part of their training program. So hopefully they don't go away, but we see them as a big part of what their training is. So they'll keep having it.
Thank you. Thank you, Madam Chair.
Thank you very much. And this does actually conclude the bill hearing on House Bill 1042. We are now going to move to House Bill 1087. This is healthcare facilities, surgical smoke evacuation systems. Delegate Johnson, if you want to approach the table and bring your panel, and you can start your testimony when you're ready.
Good afternoon, Madam Chair, Vice Chair, members of the Health Committee. For the record, I'm Delegate Steve Johnson, here to present House Bill 1087, Healthcare Facilities, Surgical Smoke Evacuation Systems. We hear all the time, what an easy bill when we have presenters. But let me tell you something. This bill is as easy as flipping a switch. House Bill 1087 is a rare kind of legislation. It will meaningfully improve the lives of essential workers, has no physical note, and has no written or oral opposition. The bill fills a gap in our laws to require hospitals to use evacuation systems during procedures that create surgical smoke. Many surgeries involve cauterizing a wound, which creates surgical smoke. It contains many harmful carcinogenic chemicals, bacteria, and sometimes small pieces of patient's flesh. Surgical smoke is a clear and documented danger to health of the staff and the patients in a surgery room. The average daily impact to surgical team is the equivalent of inhaling the smoke of 27 to 30 unfiltered cigarettes. On top of that, there have been documented cases of communicable disease transfers from the patient to the surgery staff through surgical smoke. Fortunately, the solution is simple and inexpensive, and most surgery rooms are already equipped. This does not require a large HVAC system, but rather a small suction tube that attaches to the tip of the cauterization tool and vents the smoke outside. A 2023 national survey by the Association of Perioperative Registered Nurses found that 94% of respondents said their facility had smoke evacuation equipment, but only 26% reported consistent use. The solution literally is as simple as flipping a switch to turn on the vent. 19 states have already passed legislation requiring surgical smoke to be vented out of the surgery room. Maryland Hospital Association has submitted an information letter. They are not opposed to this legislation because Maryland hospitals already have this venting infrastructure installed. Advocates for the bill also met with Johns Hopkins, who are also neutral. Representatives from Johns Hopkins said that while they have venting equipment in all their surgery rooms, they don't always require it to be used and often leave it up to the discretion of the surgeon. However, the nurses who breathe in the surgical smoke often don't get a say whether the smoke is vented or not, which is why we should require hospitals to use the systems they already have. You will have a chance to hear about the real impact on this bill, or the bill will have on health and well-being of nurses from the witnesses on my panel. With that, I respectfully urge a favorable report on House Bill 1087. Who wants to go first?
Okay. Good afternoon, and thank you for your time. My name is Christy Wheeler. I am a MSN, RN, CNOR, and CST. I began my career in the operating room in 2004 at the age of 19. I worked my way up from a surgical technologist, which if you don't know, when the surgeon says knife, I was the one that passed it to him, okay? And then I became a nurse because I wanted to pursue my education and expand into leadership. I could honestly speak to you to many of these bills today. I face in nursing leadership throughput issues every day. I understand the mental health crisis our state is facing and many of the challenges we have. This is a very simple bill, and this is an opportunity for Maryland to take a step forward in care for our healthcare workers because we are breathing this in and day out. I personally have lung damage. I can't testify to what caused the lung damage, but I think it's all my years of breathing in smoke every day, front and center at the field. I can also say as a mom, I had a C-section, and my son's first breath of air was surgical smoke because that's what we use in C-sections as well. So every child born in the state of Maryland is also breathing in this smoke as their first breath. This is a cause near and dear to my heart. It's a cause near and dear to our AORN members, the Association of Perioperative Registered Nurses. We have 600 members in the Baltimore chapter, which also encompasses the majority of the state members. I've been beating this drum since 2019, and this is the first year I've been able to get a bill, which is very exciting to us. And I really hope that you will be favorable for the bill and will bring the bill to a vote and move us forward in Maryland as we are behind the states around us like Delaware, Pennsylvania, and potentially can lose nursing staff. Thank you.
Good afternoon, Madam Chair, Vice Chair, and members of committee. Thank you so much for the opportunity to speak today. My name is Rose Zhang. I am an OR nurse with almost 10 years of experience and a member of Association of Perioperative Registered Nurses. I have never been a smoker. I have never smoked a cigarette, but after a decade of working in the operating room, sometimes I wonder if I should consider myself a smoker. Each day in the operating room, surgical smoke is produced when tissue is burned during procedures, which we use the cautery all the time. And research has shown that the smoke generated during the surgery can be the same to the exposure of smoking 27 to 30 cigarettes a day. So surgical smoke contains more than 80 toxic chemicals and biological materials, including gases, carcinogens, bacteria, and viruses. And studies also show that operating room nurses have a 69% greater risk of developing chronic obstructive pulmonary disease compared with those who have never worked in the operating room environment. Each year, more than 500,000 operating room professionals in the United States, nurses, surgeons, surgical technologists, anesthesia providers, and neuromonitoring providers or radiology technicians are exposed to surgical smoke. To put that into the perspective, that is enough people to fill the Baltimore Ravens Stadium nearly 7 times. We already know how to reduce the risk. Smoke evacuation systems are effective and readily available. In fact, 20 states have already enacted regulations requiring surgical smoke evacuation, including our neighboring states of Pennsylvania, Virginia, and West Virginia, Delaware. House Bill 1087 represents an important step for Maryland to join these states in protecting the health and safety of healthcare workers. Healthcare professionals dedicate their careers to protecting patients. Today, I respectfully ask that you also protect the people who care for our patients by supporting House Bill 1087 and bring this bill to the vote. Thank you for your time and consideration.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Jamie DeMarco, and on behalf of the Maryland Nurses Association and our members, some of whom you see here, we urge a favorable report on HB 1087. I want to thank the delegate for bringing this bill. I also want to thank the Maryland Hospital Association for their close work they did with us on this bill. We had a lot of conversations, and we're glad that they found that they're already compliant in terms of having the infrastructure, and we're grateful for their neutral testimony today. I want to just spend a brief moment to list some of the other things that are included in surgical smoke. We mentioned benzene earlier. There is no safe level exposure to benzene. It is a carcinogen. Hydrogen cyanide, formaldehyde, bioaerosols, dead and live cellular material, blood fragments, and as we heard, viruses. This is strictly not necessary, and we have the infrastructure to evacuate the smoke. We should evacuate the smoke. As we heard earlier, 90% of these facilities of hospitals asked said that they had these equipments to vent the smoke, but less than 26% are using them regularly. So let's flip the switch. We urge a favorable report.
Thank you for your testimony. I'm going to go ahead and open it up for questions from the members, starting with Delegate Riley.
Chair, I guess this could be for whomever can best answer it. So I'm just curious, why are the physicians not electing to use it? Because they're in the same room, right, and being affected as well?
Yeah. Surgeons are very set in their ways, and they do not like change. And yet they signed up for a business of change in medicine. And that is part of our barrier, is a lot of times when we do education, I did extensive education at University of Maryland, and our cardiac surgeon team decided to switch. And they really took it to heart, but it's a hard sell for us. And again, like he said, we're just the nurses in the room, and we're not necessarily in control of that OR. The surgeon is in control.
Smart people. I was just wondering why
They are smart
they're
people,
not
but-
using it. Okay,
Yes.
Thanks.
Thank
Appreciate
you.
it.
Delegate Taveras.
Thank you, Madam Chair. I'll just be quick. Why are there any proper vents in the rooms?
So operating rooms actually operate under positive or negative pressure, so it's a whole airflow system, and that is designed to prevent infections for patients as we're working. This is a specific piece of equipment that we use. It's about yay big, and it produces smoke because we're burning tissue. And so what we want is this little tube that goes on top of the equipment that goes into a HEPA filter. And that filter filters out all these carcinomas and everything else so that we're not breathing it in. So it's not a change for the ventilation system because that is already in place and set up. It's a change of using this little HEPA filter that's already on the majority of our equipment we own in the operating room to suck away this harmful smoke from our
Or may I follow? Or even yourself wearing HEPA filters?
We do have the ability at University of Maryland. We have several hospitals in the state that have already gone what we call a smoke-free, meaning they have implemented their ORs completely use the HEPA filters to remove the smoke. Because like I said, the majority of us already have it in-house. It's just taking the next step to actually using it.
So what impedes you?
I'm sorry, I didn't hear you.
What impedes you from using it?
Not having the legislation to back us up. We have no foothold to stand up against surgeons who say, no, I'm not going to do it.
Thank you.
Delegate Hill.
That was good. So I just want to understand your experience. So just full disclosure, I'm a surgeon. So I'm in the operating room. We've got lots of things, and sometimes it's on the bovie, and sometimes it's a freestanding thing, or
Right.
sometimes you use the suction machine. There are lots of ways to do it.
Right.
But I just want to understand, are you saying that your experience is that if the smoke begins to fill and you say to the surgeon, could you turn on the smoke evacuator, they say, no, we're not going to do it?
Yes.
Interesting. Thank you.
Seeing no further questions, thank you very much for your testimony. This does conclude the bill hearing on House Bill 1087. We are now going to go to House Bill 1047, which is the State Board of Physicians Delegation of Duties Alterations. Delegate Hutchinson, if you want to go ahead and approach the table, bring your panel, and you can begin your testimony when you're ready.
So good afternoon, Madam Chair, Vice Chair, members of the committee. I'm Tom Hutchinson from District 37B on the beautiful Eastern Shore, presenting House Bill 1047, State Board of Physicians, Delegation of Duties. This is a bill to once again help with the workforce shortage that we're having throughout the state. And what is actually pretty darn cool about this bill is that these two witnesses on both sides of me vehemently opposed this bill 2 years ago that we're going to expand, and look at where they are right now. So this is pretty awesome. In 2024, I introduced a bill that's now in statute that created a new healthcare occupation called a limited scope X-ray machine operator, an LXMO. So LXMOs can perform basic X-rays of chest, spine, and the extremities after successfully completing a limited X-ray educational program consisting of 115 hours of didactic training and 480 hours of clinical training. In the 2 years the LXMO has existed, it's proven to be successful in addressing the shortage of rad techs in Maryland. And in fact, there's a letter of support from LifeBridge Health where they have found it to be extremely helpful in their urgent care centers. However, during this period, it's been brought to my attention that students who are actually pursuing the career to become a full radiologic rad tech have completed the same level of training needed to be an LXMO. So this bill is really, really simple. Page 11, lines 14 to 15 is the gist of the bill. It simply states that an individual who has successfully completed the first year of an accredited RT program in good standing with the Board of Physicians can also perform limited scope X-rays. Then once they complete the program, they will advance to being a full RT and have the ability to expand their scope. That's what the bill does, pretty simple. All the other components of the bill, there's a lot of bold in there. That's just a lot of cleanup that the Board of Physicians did in the bill. So I ask for your favorable support on House Bill 1047.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Danielle Varanian, and I'm an attorney who represents the Maryland Radiological Society, excuse me, and RadNet. And I'm here to request a favorable report on House Bill 1047. This is an important bill that, as Delegate Hutchinson said, looks quite a bit more complicated than it actually is. The only new portion of law in this bill addresses those first-year RT students who meet those levels of qualification to become a LXMO. And this is important because it essentially is an extension of Delegate Hutchinson's bill from 2 sessions ago. These students have the requisite level of education and training that is required to become a LXMO. And it's important because this broadens the viable pool of candidates who can perform these limited X-rays, ensuring that Maryland patients have access to safe and quality care. For this reason and everything that Delegate Hutchinson said, we urge your favorable report on House Bill 1047. Thank you.
Good afternoon, Madam Chair, esteemed panel. My name is Kim Bathurst, and I am a Maryland licensed radiologic technologist with over 38 years of experience. 2 years ago, I testified to this committee concerning the LXMO bill, and the end result was a collaboration on a final bill that included modifications that ensured that Maryland's practicing LXMOs had a strong education and a clinical competencies, along with supervision standards in order to practice safely with focus on quality for Maryland patients. The goal was to increase patient access to general radiography imaging at outpatient orthopedic and urgent care centers to offset ED services and patient wait times. Unfortunately, I still must report that there is a continued shortage of fully licensed technologists in Maryland, along with a limited number of only 5 LXMOs practicing last I heard. However, what we left out of the bill was a very important group of qualified individuals that could have the opportunity to become a LXMO and assist with that shortage, and that is the student radiographer. Radiography students, after their first full year of education, have completed all of the LXMO education requirements in greater detail classroom testing, clinical time, and clinical competencies than even our Lexmo requirements entail today. The question is, why don't we allow our radiography students who are in good academic standing, complete 1 full year of education, along with their program director's approval, or has met or surpassed the educational requirements to apply and take the Lexmo board? This opportunity would allow for more general radiography Lexmos to practice in Maryland and filling some of those shortage gaps in outpatient orthopedic and urgent care center imaging. Radiography students are going to be more engaged in quality imaging because they're already invested in their education and have already committed 12 months of their life and effort into a career pathway of becoming a radiologic technologist. HB 1047 creates this added ability for students to continue to work, make money in their field of learning as they progress along their pathway of becoming a radiologic technologist. Thank you.
Good afternoon, Chair, Vice Chair, and members of the committee. My name is Madeline Del Greco with the Maryland Board of Physicians, here today in support of HB 1047. HB 1047 reorganizes health occupations 14306, establishes an alternative educational pathway for limited X-ray machine operators, LXMOs, and establishes disciplinary grounds for LXMOs. Currently, the board is restrained in its ability to take disciplinary action against LXMO registrants and applicants due to a lack of disciplinary grounds in the statute. This means that the board cannot revoke a registration, register an individual with conditions that would protect the public, or deny a registration for failure to disclose a criminal event on an application. This is inconsistent with and contradicts the board's mission to assure quality healthcare through effective discipline and create significant public safety concerns, especially since LXMOs are intended to work in less regulated settings such as urgent cares. HB 1047 effectively addresses the board's concerns by establishing standard disciplinary grounds for LXMOs. The board considers this addition as critical to fulfilling its mission and appreciates the attention to the matter. Thank you.
Good afternoon. I'm Chair Bagnall, Vice Chair Collison, Jane Krinke here with the Maryland Hospital Association. It's better to be on the support panel. We really appreciate Delegate Hutchinson's commitment to supporting the workforce. We supported the bill back in 2024 and are in strong support of the bill this year. We think it would help expand access to care. As was mentioned, we still have a shortage of rad techs. There's currently a 11% vacancy rate in our hospital for RTs. And we also think it could help these students who are going through school to have a way to make some income while they're going through school. So for numerous reasons, we strongly support House Bill 1047 and ask for a favorable report. Thank you.
Thank you for your testimony. I'm going to open it up for questions from the members. Does anyone have questions for this panel? Seeing none, thank you for your testimony, and this does conclude the hearing on House Bill 1047. It is very nice to see you all on the same side. So we're going to move to House Bill 1143, Public Health Office of the Chief Medical Examiner, Perinatal Autopsies, Lung Float Test Ban. Delegate Lopez, if you want to go ahead and approach the table, and if you want to bring your panel, and you can begin your testimony when you're ready. And Delegate Lopez, do you want to bring both bills so you can just stay at the table? Okay, perfect. Thank you.
Come on down.
Oh yeah, go for it.
And we should have two virtual. Perfect. Good afternoon, Madam Chair, Madam Vice Chair, fellow members of the Health Committee. For the record, I'm Delegate Leslie Lopez, representing District 39, and I'm here to present HB 1143, the Lung Float Test Ban, which prohibits medical examiners from using a hydrostatic lung test known as a lung float test when performing a perinatal autopsy to determine whether the death resulted in a stillbirth or occurred after a live birth. Right now, Maryland allows the pseudoscientific hydrostatic lung float test, say that 5 times fast, to be used in postmortem assessments.
This test looks at whether air is present in the lungs, and from that and other potentially postmortem observations, instigators may infer a live birth and then assign the cause of death. Here's the problem. The lung float test has never been medically validated with controls. It was introduced in the mid-1600s, 400 years ago, and has hardly been updated. Another problem is that there's no universal standard for how the test is administered. That lack of uniformity means that the test, depending on who is performing it, can produce inconsistent results. There are many false positives and many false negatives. Thirdly, the presence of air in the lungs of a stillborn newborn can occur for many reasons and does not indicate that a newborn lived outside of the womb. Despite this lack of precision and scientific validity, the lung float test results have been used as evidence in serious criminal cases. When criminal liability is at stake, when someone can get a life sentence in prison, relying on an unstandardized, scientifically questionable test puts justice at risk. Leading organizations like the National Association of Medical Examiners and Physicians for Human Rights have identified the lung float test for its unreliability. A recent survey of practicing forensic pathologists showed that 2/3 do not think the lung float test is reliable. There is, however, a clear path forward. Modern forensic guidance is clear. Determinations of live birth should be based on multiple evidence-based indicators, scene investigation, medical history, placental examination, and a full autopsy. All tools that medical examiners will still have upon passage of this bill. And so HB 1143 brings Maryland into alignment with modern scientific standards. It ensures that determinations of live birth and the serious legal consequences that follow are based on clear evidence. In so doing, it also protects families experiencing miscarriage or stillbirth from being subjected to intrusive, traumatic, and unwarranted criminal investigations during one of the most painful moments of their lives. This bill enforces public confidence in our justice system, and restores confidence that our justice system will respond with both vigor and compassion. And so for those reasons, I respectfully urge a favorable report. Thank you.
Good afternoon, Chair, Vice Chair, and members of the Health Committee. My name is Gabriella Watson. I am from Montgomery County, Maryland, but today I'm here to speak in favor of HB 1143 on behalf of Pregnancy Justice, a nonpartisan organization that works to advance and defend the rights of pregnant people. Shortly, you will hear from legal and forensic experts on the dangers of using the lung float test in criminal cases. But I wanted to highlight the very real and devastating stories of our clients and why we urge to ban the use of the discredited forensic test. Right now, we are representing 2 women who are charged with murder for their pregnancy losses based on the lung float test, and recently filed an amicus brief in support of a 3rd. Just last week, we heard from another woman who is being charged with murder for a pregnancy loss that occurred years ago based on the use of the lung float test. Behind each one of these cases is a woman, often a mother, who has been investigated, prosecuted, and incarcerated following a tragic and traumatic pregnancy loss. One of our clients is a 55-year-old woman with no criminal record who was charged and arrested for murder based solely on the use of the lung float test, conducted over 30 years ago following a stillbirth that she had in college. The arrest has taken her away from her disabled husband and a full-time job helping veterans. Right now, she is sitting in a county jail awaiting trial, unable to pay the $1 million bond imposed by the court. In total, we're aware of 16 cases since 2013 in which a woman's pregnancy loss was transformed into a criminal act by the use of the lung float test. In several of these, the test was the sole piece of evidence used to convict the woman of murder. But because of how difficult it is to find these cases, this is likely an undercount and an underestimate of the real toll this test has had on the lives of the women, their families, and their communities. With HB 1143, Maryland has the opportunity to be the first state to codify a lung float test ban and to continue to lead the nation in supporting reproductive justice. Thank you.
And we have 2 virtual witnesses. So if we can, Aziza Ahmed, if you want to go ahead and unmute and begin your testimony, and then we'll go to Stephen White.
Thank you so much. Can you hear me?
Yes, we can.
Okay, great. Thank you so much, and good afternoon, Madam Chair. My name is Aziza Ahmed. I am a law professor at the Boston University School of Law and the co-founder and co-director of the Boston University Program on Reproductive Justice. I'm here in support of HB 1143. The issue of stillbirth and miscarriage is widespread in the United States. 1 in 150 pregnancies end in a stillbirth, and that number is even higher among poor women and high in minority communities of Black, Native, and Latinx people. A large number of these stillbirths and miscarriages have no cause. In instances where stillbirths occur at home, women are often suspected of killing the child no matter what she reports. The post-Dobbs legal environment furthers suspicion of women's behavior during pregnancy, especially where states seek to criminalize self-induced abortion. In our fast-changing political environment, it is important to recognize that fear of medical racism, fear of immigration detention, and concerns about cost incentivize women to stay at home even if they're having difficulty with pregnancy or are in labor. Given this legal environment, it's important to exercise the utmost precaution and care to be utilized in investigations of stillbirth. Unfortunately, assuming our shared goal is a fair trial and an ascertainment of fact before false accusations and declarations of guilt, the lung float test undermines the criminal justice process rather than further it. Though the lung float test has the valence of a scientific test, we know that it is widely mistrusted by medical pathologists and forensic scientists, as seen in the recent National Association of Medical Examiners position paper on the test. Why has this test remained in use if we've long questioned its veracity? It's well known that our current legal process, even beyond the lung float test, does not work to effectively remove junk science from the court. Judges and juries are ill-equipped to deal with scientific questions, and our evidentiary standards provide wide latitude for judges to admit faulty evidence into trials. Cross-examination has been ineffective in keeping the lung float test out of use. The best way to address this issue of falsely identifying an infant as having been born alive and holding a person pregnant accountable is to ban the test. This ban would be in line with accepted scientific understandings of the test, as well as remedy defects in keeping the test out of the courtroom. And Maryland can be the leader on this, and we really encourage it. Thank you.
Thank you for your testimony. Mr. White, if you want to go ahead and unmute and begin your testimony.
Thank you. Good afternoon, Madam Chair, Vice Chair, and members of the committee. I appreciate the opportunity to speak and in support of HB 1143. I'm Dr. Stephen White. I'm a practicing forensic pathologist for over 15 years now. I also have experience in training in perinatal pathology, so examining fetuses, stillbirths. I also teach medical students and pathology trainees. And it's so important that as medicine progresses, we use evidence to inform our practices. Tests used in medicine must be validated. They must undergo rigorous study to ensure that the test results are accurate, reliable, and reproducible. In forensic pathology, we already use tests for toxicology, drug analysis, looking for viruses, bacteria. All these tests are validated, and we use those in our daily practice to diagnose diseases and determine why people die. The lung float test has never been validated. It's never undergone the same tests that we use in clinical practice. We would never use a test that has never been validated to send someone for surgery or to prescribe a medication. Yet this test is still used by some pathologists and to determine if a fetus was born alive or not. And then that is further used by the courts in prosecution and sending people to jail. And so the stakes are very, very high here. The National Association of Medical Examiners acknowledges that the lung float test should not even be considered a test because it has never undergone the requirements to become a test. It's never undergone the rigorous study in a forensic setting. There have been some studies in hospital settings which have produced variable results, but no studies in a forensic setting with forensic cases. So as I teach my students and my pathology trainees, the lung float test is unreliable, not reproducible, and we should not be using it in diagnosing whether a child has been born alive or stillborn. Again, I support the ban of the lung float test, and I appreciate your time.
Thank you for your testimony. I'm going to open it up for questions from the members. Vice Chair Cullison.
Thank you, Madam Chair, and I think this is a question for Dr. White. I'm reading through some of the letters of concern and saying, there seems to be a lot of debate about the efficacy of the test. But one of the major issues seems to be the authority of the medical examiner to be the final arbiter on which tests they use. And there, in one of the letters, it says, no other test has ever been precluded. So the question I have for you is there a test that you feel has been validated, has shown high efficacy, and it proves the same thing in terms of, I guess it's really at the point of death of the infant?
It's a good question, and no, there has not. What we use are investigative clues. We use things like microscopic examination, which has been validated. We can look at the tissues under the microscope and use that. There is no other test that's been validated. I can say that all of the tests we do use, other than the lung flow test, have been validated. So drug analysis validated. There are no other tests that are used in the way that the lung flow test is used that have not been validated. So it's a very unique test, if you can call it that.
Okay. Thank you. Thank you, Madam Chair.
Delegate Kaufman.
Thank you, and I'll be very brief, Madam Chair, but I did want to give the sponsor a chance to respond to this. Have you seen the letter from the Board of Physicians, and are you amenable to their amendment, their proposed amendment?
Sure. Yeah, I saw that. They're looking for an exemption to not be included in part of that. I think to speak more broadly about some of the letters of concern, we are uniquely positioned as lawmakers elected by our constituents to provide oversight. And this is an area where I think we need to exert some oversight over the medical examiner's office. If they're using a test that has no scientific basis, there's no standardized protocols for how it can be applied, and yet people in very real circumstances are entangled in our criminal justice system because of that, then we need to take a hard look at it. And I hope this hearing provides an opportunity to do that. I do understand that it's uncomfortable when someone comes in and tells you what to do, but sometimes people need that. So there you go.
Thank you, Madam Chair.
Delegate Johnson.
Madam Chair, for Dr. White, so there's not another test, but you do have other tools that you can use to make these determinations?
Yes, that's correct. We have an array of findings, such as food in the stomach, microscopic examination, scene findings, and examination of the body that we do with all of our cases that can help inform us. Sometimes there's no way to know, but there are other ways of assessing it. It's just the lung flow test doesn't add any value because it's all over the place.
Thank you, Doctor. Thank you, Madam Chair.
Delegate Shalega.
Thank you. Do other states use this test, or is there some other method they use to determine if a child is stillborn or born outside the womb, or dies outside the womb?
That might be a better question for Dr. White or Ms. Ahmed.
I can say that it's not regulated at the state level. I would say the vast majority of practicing pathologists, forensic pathologists, do not use the test because they know it's unreliable. People have been teaching this for years now. It's just there are a few that still hear, that it could be reliable. It sounds very simple. You breathe in, it floats. They don't. But I would say the vast majority don't. We use the other investigative tools that we have during an autopsy to make that determination.
Thank you.
Seeing no further questions, this does conclude this panel, not this hearing. This does conclude this panel. We do have one unfavorable virtual witness, and that's Laura Bogley. So, Ms. Bogley, if you would like to unmute, you can give us your testimony. Please unmute and give us your testimony.
Good afternoon, Madam Chair and members of the committee. I'm Laura Bogley, Executive Director of Maryland Right to Life, and we urge your unfavorable report on this bill. This bill is yet another bill, not just another abortion shield law, and must be considered in light of its companion bill by the same sponsor, the Pregnancy Outcome Protection Act, that would effectively legalize infanticide by third parties in order to shield the abortion industry. By enacting this bill into law, the Assembly will be denying justice for infants and their families. The bill ties the hands of medical examiners and medical providers in Maryland by prohibiting an important and affordable tool used reliably for centuries to determine whether an infant was stillborn or the victim of infanticide. Lung float tests have been used reliably since the 17th century, excuse me, and there is no history of false positives when the test has erroneously established that a child was the victim of infanticide. When the test has failed, it resulted only in false negatives, when the test showed an infant was not born alive in conflict with other medical evidence. In fact, a study published by PubMed proved that the results of floating tests are 98% reliable. While we agree with other pro-life organizations that prefer newer, more comprehensive methods of testing for live birth, such as postmortem CT and histopathology, without federal funding or a federal mandate like the Born Alive Abortion Survivors Protection Act, currently before Congress, that requires medical care and triggers a formal report, the shift toward better science will result in no science, as survivors will never be identified or deaths will never be referred to the medical examiner for these sophisticated tests. Prohibiting this test entirely before modern alternatives are mandated effectively grants immunity to those who neglect born alive infants, causing their demise. Finally, I want to remind this committee that under federal law, specifically the Born Alive Infants Protection Act of 2002, newborn infants are legally protected persons and are owed all rights due to persons under the Constitution of the United States. Once the child is born, even if it's the result of a failed abortion, those legal protections are triggered. For this reason, we ask you to issue an unfavorable report, and I'm happy to take questions. Thank you.
Thank you for your testimony. Are there any questions from the committee for this witness? Seeing none, thank you for your testimony. This does conclude the bill hearing on House Bill 1143. We are now going to go to House Bill 1135. This is health occupations, pharmacists, vaccination orders. Delegate Lopez, if you want to approach the table and bring your panel, and you can begin your testimony when you're ready.
Good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. For the record, I'm Delegate Leslie Lopez, representing District 39, here to present HB 1135, Pharmacist Vaccination Orders. At its core, this bill is about clarity, helping professionals do their job, helping patients access care, and helping how our government keeps pace with modern medicine. HB 1135 makes a narrow technical update to Maryland's law so that pharmacists may prescribe and dispense FDA-approved vaccines that are designed for self-administration when clinically appropriate. It does not create new vaccines. It does not expand eligibility. It does not mandate use. It simply resolves a technical ambiguity. All vaccines used in Maryland, including those administered by pharmacists, are rigorously tested and approved by the FDA. They undergo robust evaluation for safety, efficacy, approved methods of administration, age-specific use, and proper dispensation. This ensures that every vaccine provided in the state meets high standards of public health protection. This bill does not change Maryland-specific law, which allows pharmacists to provide vaccines only to children 5 years and older. But it is important to note that current influenza vaccine nasal spray is FDA approved for children as young as 2 years old. Maryland has long recognized pharmacists as trusted partners in public health. They already administer a wide variety of vaccines under rigorous training, reporting, and clinical standards. They screen patients, counsel families, and maintain life-giving skills like CPR certification. Pharmacists ensure vaccinations are reported to the state registry, so care remains coordinated and accountable. These are not theoretical responsibilities, they are daily practices that Marylanders rely on. Reliance on pharmacists is growing, not shrinking. Pharmacies are among the most accessible healthcare locations in our communities. During recent public health emergencies, pharmacy teams delivered hundreds of millions of vaccine doses nationwide, demonstrate not only their capacity, but the public's trust in their care. Maryland reflects this reality with increasing numbers of residents turning to pharmacies for routine and preventative services. What this bill recognizes is simple. When science advances and federal approvals evolve, our statutes must keep pace. If a vaccine is approved by the FDA for self-administration, like a nasal spray, and if a licensed pharmacist is trained, regulated, and accountable for patient care, then the law should clearly allow that professional to serve the patient. This is the barrier addressed by HB 1135, and it's not medical, it is technical. And this technical barrier requires practical solutions that make our systems more efficient. Importantly, nothing in this bill weakens oversight or patient protections. HB 1135 does not expand policy. All existing Maryland-specific safeguards remain in place. Professional standards remain unchanged. Public health reporting remains intact. What changes, however, is clarity. Clarity that supports access, continuity of care, and a healthcare system that works as people actually experiences. And for those reasons, I respectfully urge a favorable report.
Go for it. Okay. Chair Bangle and members of the committee, my name is Alan Bandel, and I'm the U.S. medical lead for influenza at AstraZeneca. AstraZeneca is a global science-led biopharmaceutical company here, and Maryland is has the largest footprint for U.S. employees, including advanced manufacturing and research and development. We employ over 5,500 folks from Maryland across sites in Gaithersburg, Frederick, and Rockville. AstraZeneca appreciates the opportunity to share its support of House Bill 1135. Vaccination practices are strongest when patients are offered multiple complementary pathways to care, which specifically reduce barriers to access. This bill updates Maryland's law so residents can access vaccination through modern FDA-approved delivery approaches. As new forms of vaccines become available, it's important that the same laws clearly enabling pharmacists to participate in those models in a way that is consistent with their training and responsibilities. And pharmacies are trusted community-based access points, and pharmacists, as you've heard, play an important role in helping patients navigate vaccination options. This change does not disrupt existing care. Patients can still get vaccinated in physician offices, clinics, and pharmacies, but it does provide an opportunity that adds much-needed flexibility for patients, parents, and caregivers who need it. Importantly, safety and oversight are built into the system, as these are FDA-authorized prescribing information, defined eligibility criteria, adverse event reporting, and pharmacists establish protocols for screening, counseling, and follow-up, and importantly, immunization registry reporting through Immunet. HB 1135 is a pragmatic step that strengthens public health, expands access, reduces barriers, preserves patient choice, and reinforces pharmacists as accessible healthcare providers. On behalf of AstraZeneca, we respectfully urge a favorable report on HB 1135.
Thank you.
Madam Chair, members of the committee, Bernie Marzik from Cornerstone Government Affairs here today on behalf of AstraZeneca. I want to thank Delegate Lopez for introducing this important piece of legislation that will increase access to vaccinations across the state for Marylanders. We'd also like to thank the Department of Health and the Board of Pharmacy for their support of this legislation. Delegate Lopez said this is a narrow technical clarification to Maryland law for vaccines that are intended for self-administration rather than physical administration, as we have seen this evolve. This is not a scope expansion, a mandate, or a new program. This bill simply clarifies that when a vaccine is designed for self-administration, pharmacists may prescribe and dispense it consistent with their existing professional standards and regulatory oversight. Nothing in the bill creates a new vaccine, expands who may be vaccinated, mandates use, or alters existing vaccination programs. This bill preserves oversight for the pharmacist while allowing the system to function as it is intended. So I will end there because I just want to reiterate the comments by the sponsor, and we'd be happy to answer any questions.
I also have on your sponsor panel, Delora.
I'm here with, Delora and I both signed up because we weren't sure who was going to be able to be here.
Great, and also Aaliyah Horton. And then we'll go to your virtual witness, Aaron Levin.
Hi. Hi, Chair and members of the committee. My name is Aaron Levin, and I am a Maryland resident. I appreciate the opportunity to testify in support of HB 1135. I'm here today because vaccines are important everyday shields to help keep parents and kids healthy and let our kids learn, play, and grow safely. As a parent, I juggle work, school schedules, and the usual childhood illnesses. Even for a family that believes in immunization, access isn't always simple. Wait times for appointments, transportation, school and work commitments are all barriers to this important public health tool. That's what this is about, keeping kids in classrooms, parents at work, and communities thriving. Missed vaccinations may lead to hospital bills, long-term complications, or lost wages in schooling. Increasing access doesn't mean forcing care. It means removing friction so willing families can say yes. I ask you to support HB 1135. When vaccines are convenient and affordable, uptake rises and outbreaks fall. That protects newborns not yet eligible for vaccines, grandparents on chemotherapy, and kids like mine who just want to be healthy enough to show up for life. Thank you for your time and for safeguarding the health of our community.
Thank you for your testimony. And Aaliyah Horton?
Yes, good afternoon. Aaliyah Horton with the Maryland Pharmacists Association in support of HB 1135. Just wanted to mention that this, again, is a bill for clarity. And I will tell you, we've been discussing this for probably 2 years about whether pharmacists could dispense this medication or not. This legislation is based on feedback from the Board of Pharmacy as well as the AG's office, and so it's passed those tests, I'll just say that. And we want to make sure that patients can access vaccines where they are and how they want to receive it, and this will enable that to happen. And one thing that I do want to mention that will probably come up in the opposition testimony is around the role of the caregiver. And I wanted to just provide this clarification for the folks who are newer to the committee, and that we've addressed this over the years, but caregiver is used throughout Maryland code to ensure flexibility related to parental consent. Health General Section 18.4A spells out parental consent, and it defines parents and includes an explicit list of individuals who parents can authorize to give consent for a child. Even babysitters, teachers, and school nurses do not have those rights. So I just wanted to remind the committee about that. And again, this doesn't really change a lot in terms of the broad scope of pharmacist authorization for vaccinations. It's really about the modality and providing that to patients. Thank you, and urge a favorable report.
Thank you for your testimony. Are there any questions for this panel from the members? Delegate Kipke.
Thank you, Madam Chair. I think to the lady from AstraZeneca, is there any, one thing that I think about is with children with divorced parents, and what if they were to get 2 of these, let's just say the flu mist? Is there any concern about that? Are there any negative health effects of getting 2? And then I'll just ask the second question. There is some testimony about concerns about, since it's being administered by, I assume, a parent, or it's not being administered by the pharmacist, is there any concerns about, monitoring for side effects?
Yeah, so Alan Bandel with AstraZeneca. So in regard to potentially getting 2 doses, so vaccinations are documented in your immunization registry. So the parent goes online and would fill out a screening form. So if one parent, let's say, is not speaking to the other and doesn't fill it out correctly, the pharmacy checks for patients to see when they got their previous vaccine, if they even had the vaccine. So they would have documentation, whether it was given actually at a provider's office or through a home delivery service like this. So there are checks in place that would prevent that from happening. I don't know if you have anything to add to that. So that takes that into account. Additionally, the vaccine is such that most children, in their first time they get flu vaccine, they do get 2 doses, 4 weeks apart minimally. So a second dose would not necessarily be harmful, but likely would not be needed in that case. And then the other question you had was about, are you concerned about the competency of a parent or caregiver administering the vaccine?
When I got the COVID shot, they made us sit. We were monitored for a while because they were worried people would pass out.
Right.
And I guess some people did. I understand that this is not exactly the case, but is there any concern that a untrained individual without medical expertise, they're not looking for the side effects? Is there any concern with this category of vaccine?
Right, so this is an intranasal vaccine, and what you're concerned about why we have folks sit afterwards is because of syncopal or a fainting event that occurs quite infrequently with nasally administered vaccines, because we administer a lot of things nasally, and we've not seen it occur outside of the traditional healthcare provided vaccination. Most likely what we see is in a couple days, patients develop runny nose and stuffy noses, which is, we actually expect that to happen. So it is not a concern.
Thank you. Can I ask one more question? I'm sorry. Is that right? I'll allow it. Thanks. Aaliyah, are there any other vaccinations that fall into this category that are authorized by this bill?
I am not aware of any, but I can follow up and get back to you.
If you would, I'd really appreciate it. Thank you.
Delegate Chalega.
Thank you so much. So I would respectfully say it is a bigger change because we're now saying ordered for administration by an adult caregiver, not a parent. Can you walk me through how this will be ordered, administered, and reported? What would this look like?
So it's actually quite a sophisticated system that we work closely with FDA and a pharmacy to develop. So they would go online, they fill out actually a form that is very similar if they were going to a retail setting. So if you recall, if you've been vaccinated in a retail setting, you go online, you provide your information, you might provide some critical health information, and they would then it comes up in the retail setting what vaccines you're eligible for or supposed to get. It's very much like that. Parent would go in, provide their information, patient's information, or their own, provide the insurance information and any critical health information, and then the pharmacist determines eligibility. And then upon eligibility, the patient can choose, the family can choose when the vaccine is delivered to the house, which is done under very strict cold chain logistics. That's tested, the shipping is good, box is good for 68 hours, and that's tested and validated with FDA. And patients can actually test to determine if the box was outside of temperature during transportation. And then once they get the box, it's unpacked and put it in the fridge and then used usually within a few days. And then they validate, they affirm with the pharmacy that they've taken the vaccine, and then it's reported to your registry.
So that's when it gets reported to ImmuneNet?
Yes.
Okay. And so why is caregiver in there? Because that may be the person that picks it up. Can a caregiver go online and do that? Or just a parent?
I use the terminology caregiver. It's just one that I became familiar with, but essentially we're talking parent or guardian, the person who has the ability to make healthcare decisions.
Can go. Then why do we need caregiver in there?
I was going to say, I think, Ms. Horton, I think you're able to answer that question. Am I correct?
Yes. Or do you want me to expound upon that? Oh, okay.
I know you mentioned.
Because I have to read it.
You mentioned that in your testimony, but.
Yes, but I can elaborate on that a little bit.
Yes.
This does get into more pharmacist scope than what I am typically responding to. But what I will say is that this is a self-administered medication. And so there are, for minors, it would not be self-administered. The caregiver would provide it. And so they would be administering the medication. And so that's why it's in there.
Thank you.
Delegate Hutchinson.
Chair, and I'm sort of sorry if I missed this, but I'm glad Delegate Kipke asked if it was more than just flu mist. We see the word vaccination in here, but is flu mist considered a vaccine? I always thought that was when you were having the symptoms, then you would take the flu mist, or that's how a vaccine works. Just clarify.
I believe that one's Tamiflu.
Okay, so we're talking different than Tamiflu.
Correct.
This is a medication that should prevent you from ever even getting the flu.
It is a vaccine that's been approved and used in the United States since 2003.
Great, thanks for clarifying that. Thank you.
Seeing no further questions, thank you very much for your testimony. We do have one unfavorable virtual panel, so if we can bring up Sarah Cusack, Catherine Garrett, and Megan Montgomery. And Ms. Cusack, when you, if you can go ahead and unmute and begin your testimony.
Caregiver is defined in the federal, it's in U.S. code. It is like it defines it. I remember that being in the one that sent us for the other one.
Okay, Ms. Cusack, if you want to go ahead and unmute and begin your testimony.
Absolutely. Thank you. Good afternoon, Chair Bagnall, Vice Chair Cullison, and committee members. I'm Sarah Cusack with the Alliance for Science-Based Policy. For over a decade, this committee considerately debated whether to allow children to be vaccinated in a pharmacy. When the state did allow it, they were sure to include that pharmacists had to undergo hours of training. This bill throws those considerations out the window. Now, a pharmacist will order a flu vaccine that will have to be transported to a home under careful, appropriate temperature conditions, where an untrained caregiver will have to read materials or watch a video that are currently only available in English to learn how to administer the flu vaccine. Then this caregiver will have to pack up and appropriately dispose of the kit contents, as this product is made of live virus and it is serious medical waste. The bill does not say that it is only for the flu mist, so we have no idea what other kinds of products could be ordered for 3-year-old children in the future. Our organization advocates for children to be thoroughly assessed in person by their healthcare provider, preferably a physician, as vaccination is a medical procedure that has benefits and risks. Please read the testimony I included from my friend Tina Young. She could not testify today. Her beautiful daughter Jasmine suffered severe disability and death following a routine flu vaccination. Please do not trivialize the importance of proper assessment, training for administrators, and informed consent for vaccination by passing this bill. Thank you.
Thank you for your testimony. Ms. Garrett, if you want to go ahead and unmute and begin your testimony.
Madam Chair and members of the committee, thank you for your time today. My name's Catherine Garrett, and I am the chair of the Love Maryland PAC. We have over 3,600 members statewide and focus on consumer protection in the healthcare sector. I am here to urge an unfavorable vote on HB 1135, which would allow pharmacists to order vaccinations for children as young as 3 without administering them themselves. While well-intentioned, this bill dangerously expands the scope of pharmacy practice at the expense of patient safety and comprehensive care. This is a special interest bill. This is a bill for padding corporate bottom lines of companies like CVS. It is not a bill about the health or safety of minor children. If a pharmacist orders a vaccine, but someone else, perhaps an untrained caregiver, administers it incorrectly, who will bear the liability? The bill's safeguards, like reporting to Immunet, are insufficient without direct oversight. This isn't about convenience, it's about accountability. To my understanding, after speaking to several elected officials in both chambers, caregiver is not clearly defined in this part of the code. A judge could likely assume the definition to be anyone with the care and custody of a child to be considered a caregiver who could lawfully consent to and administer this vaccination. Should this bill move, the Love Maryland PAC would strongly encourage the language to be amended to remove caregiver and replace that with parent or legal guardian, as that is the only person or persons who should be able to consent to the vaccination of a child. Finally, this bill, like so many others we have seen since COVID, erodes the role of a primary care provider, which leads to fragmented medical care. The best location for vaccinations and discussions about vaccinations is with a primary medical professional. The Love Maryland PAC strongly encourages an unfavorable vote on HB 1135. Thank you.
Thank you for your testimony. Ms. Montgomery, if you want to go ahead and unmute and begin your testimony.
Thank you, Chair Bagnall and members of the committee. I'm with the Alliance for Science-Based Policy, and I too come to share our concerns. First, as I stated in my testimony, if you do nothing else, please read the insert for the flu mist vaccine before you pass this bill. This is not, the bill does not say just flu mist, so there are more vaccines potentially coming down the pike that are eligible for in-home administration, and this is not a simple procedure. We are very concerned that any child covered under the Vaccines for Children program would be ineligible for this. Those vaccines, according to the rules of the program, must be administered in person. We too have grave concerns about the word caregiver. If the intention is for parents to do this, the law absolutely allows for the word parent to be placed into this statute, into this bill, if it becomes statute. 14-year-old babysitters should not be administering vaccinations to toddlers. That should make all of us very, very nervous. These are children, supervising children under the care of a parent or guardian, that should not be responsible for administration of a vaccine, watching the video, and disposing of medical waste of a live virus product. That is very, very scary. And as we learned from the testimony of the sponsor panel, the Immunet reporting happens afterwards. As I understand it, the Immunet tracking is actually going to be done by address. Divorced parents have 2 addresses. These children could very, very easily be doubly vaccinated, and we would not find out until afterwards or maybe ever, and the FDA has not approved that. So please read my testimony and deliver an unfavorable report. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Seeing none, thank you for your testimony today. This does conclude the bill hearing on House Bill 1135. We are now going to go to House Bill 1021, our final bill of the day, which is Health Occupations Licensed Psychologists Prescriptive Authority. Delegate White Holland, if you want to bring your panel. And last but certainly not least, and you can begin your testimony.
Sorry. Thank you so much. And again, good afternoon, Madam Chair and fellow members of the House Health Committee. For the record, I'm Delegate Jennifer White Holland, and appreciate the opportunity to present HB 1021, Health Occupations Licensed Psychologist Prescriptive Authority, for your consideration. This session and in prior sessions, we are continuing to increase access to care and strengthening workforce pipelines, especially related to mental and behavioral health. In Maryland, our constituents are often forced to choose between waiting months for an appointment or paying high out-of-pocket expenses. HB 1021 does not address all of the systemic issues related to our mental and behavioral health system. However, it is a tool that would expand the pool of authorized prescribers to include licensed psychologists who have met rigorous postdoctoral requirements within a larger context of guardrails to ensure the health and safety of patients. This will work to address the need for more responsive and robust mental health workforce by allowing qualified individuals to manage both therapy and medication. And essentially, we eliminate the need for the referral loops, which currently leaves patients stranded. I will invite my panel to expound upon the provisions of the bill, outlining the various guardrails and educational requirements, collaboration with licensed medical providers, and documentation required for the board to maintain to ensure the health, safety, and welfare of our constituents. As the culture of this committee, we have had stakeholder meetings with proponents and opponents of the bill. Unfortunately, we have reached an impasse, and no clarifying language or other resolutions have been offered to meet in the middle. And so we look forward to further discussions. We've also reached out to the Maryland Board of Psychologists, and I'm sure you have seen their letter, but was unsuccessful in connecting with them ahead of this hearing. As such, we continue and will continue to remain at the table and look forward to having further discussions in subcommittee. I am grateful again and appreciate you all taking the time to hear this bill, and I respectfully request a favorable report and will now invite my panel to share further about this bill.
Madam Chair, Madam Vice Chair, Dan Shattuck here today on behalf of the Maryland Psychological Association. With great appreciation to Delegate White Holland for bringing this bill forward. It's timely. You've heard in this committee for many years and a lot this session about the high levels of need for mental health care, the barriers to access, and we think this bill does a number of things. It's going to address continuity of care. It creates a pathway to unify care and avoid the referral loop that the delegate mentioned. It improves access to care by adding a qualified and trusted provider into this prescribing space. And it's not going to be every psychologist, and the rest of the panel will speak to that. It builds on an evidence-based and documented train of success. 7 states have chosen to move forward with this as far back as 2002 and as most recently as Utah in 2024. The military was the birthplace for this, and you'll hear somebody speak to that later. Back in 1991, the early 90s or late 1900s, depending on how you want to look at it. This bill was crafted with a number of safeguards. We've got barriers and guardrails with respect to the formulary. It's only going to be those medicines that are used to treat mental health conditions. There's going to be coordination of care. The psychologists are going to have to refer and interact with the medical provider that's been providing the prescriptions, whether that's primary care, which does a predominant amount of the prescribing in the space, pediatricians, psychiatrists, psychiatric nurse practitioners. There's a potential for decrease in patient burden, going back to the continuity of care and avoiding referral loops. There's a lot of we've intended for the bill to have multi-board involvement. Yes, multi-board involvement and with the Board of Physicians, the Board of Pharmacy, and again, you're going to hear in more detail from the panel. And just to follow up on the delegate's statement, we understand that the Board of Psychologists did express their concerns directly to you. We do stand ready to talk and work through any amendments from anyone, for that matter. So we urge a favorable report, and thank you for your time.
Dear esteemed Chair, Vice Chair, and members of the committee, I'm Dr. Peter Smith, President-elect of the Maryland Psychological Association, and I'm here to encourage a favorable report on this bill. Training to be a prescribing psychologist, referred to as RXP, is an extensive and thorough process that involves a doctoral degree with advanced training in clinical psychopharmacology, with earning a Master of Science in Clinical Psychopharmacology degree with combined training of over 10,000 hours. Different training does not mean deficient training. The coursework in an MSCP program takes at least 2 years. Content areas include basic sciences, functional neuroscience, physical exam, ordering and interpretation of lab tests, pathological basis of disease, clinical medicine, pharmacology, clinical pharmacology, and psychopharmacology. This training ensures coverage of all major body systems and for proper monitoring of specific medications and adverse drug events. In addition, prescribing psychologists are trained in conducting physical assessments, and a clinical fellowship is a minimum of 400 hours. Prescribing psychologists are providing demonstrable benefits without demonstrable harm. Research indicates that states with RXP have a reduction in racial disparities in pediatric mental health, especially for non-white children, lower rates of death related to mental health, and if adopted, potential reduction in prescriber shortages. The Trust, a liability insurance provider, noted that the surcharge for prescribing psychologists in the 7 states was, quote, minimal, end quote, suggesting an absence of widespread malpractice. With the adoption of RXP, I would expect increased access, including rural areas, which is important since the Investing in Maryland's Behavioral Health Talent Report noted that 6 counties have 1 or fewer psychiatrists. Prescribing psychologists provide non-fragmented care, which is a cost-effective method and less burdensome on patients when they can get their meds and therapy in one setting. Prescribing psychology is not looking to replace current providers, but to work in coordination, as outlined in this bill, with other providers to expand access to medication in a safe and appropriate manner. Thank you. Yes.
All right. Hi, thank you to the members of the committee. My name is Jess Romeo, and I'm a Maryland resident, a psychiatric nurse practitioner, and a clinical social worker. I'm here in support of this bill because my own pathway to prescriptive authority is much like that which my psychologist colleagues are asking you to consider. I'd like to start by telling you the moment I decided to become a psych NP. I was a social worker following a client to his psychiatry appointment, where we waited about 30 minutes in the waiting room for a 10-minute visit. And at one point, the psychiatrist, during a routine social history update, said, "You don't have any family, do you?" I happened to know that this client had just returned from a trip to see his 30 extended family members, and the psychiatrist didn't even know they existed, despite having a relationship with my client for 10 years. I'm not saying that all psychiatrists practice this way. I am saying that in that moment, I decided, well, I can do a little better than that. So I decided to go back to school and pursue a nurse practitioner degree, which has a similar amount of rigor to what I understand about the Masters of Science in Psychopharmacology for psychologists. What I think is very true here is that the length and duration of someone's training does not automatically determine the quality of care that's provided. And moreover, when you reduce the scope of practitioners able to engage in prescribing, it forces more psychiatrists into a role where they have to see patients every 10 minutes to be able to meet the need. So the data supports this. The rates of suicide for practices, for states that have engaged in allowing psychiatrists to prescribe, see lower rates of suicide, and nurse practitioner rates of outcomes are overwhelmingly positive. Over 150 studies indicate that nurse practitioners can provide this level of care. So my social work training before I went back to school informs every prescribing decision I make. I'm sought out because of this background, and I think my psychologist colleagues will be as well. So Maryland has already supported independent practice for NPs. They support this practice, and I believe that this bill will be consistent with Maryland's commitment. Thank you.
Hello, Chair Bagnall, Vice Chair Collison, and members of the committee. It's been a long day, and I appreciate everyone's attention at this time. I'm Dr. Stephanie Olarte. I'm a licensed psychologist and legislative chair for the Maryland Psychological Association, and I have the privilege of testifying before you to urge a favorable report on House Bill 1021. For over 10 years, I've provided psychotherapy and assessment for children and adolescents right here in Maryland. My nickname is therapist number 3. Because by the time youth make it to my office, they have typically cycled through at least 2 other providers. I have worked with everyone from low-income youth on Medicaid to elite private school youth who have every resource at their disposal. As a Latina and Spanish-speaking psychologist, I also have the privilege of working with many Spanish-speaking families. These youth all have one thing in common, regardless of spoken language or socioeconomic status. They all must wait months to receive psychiatric care. Given their often unique and acute presentations, they're more likely to cycle through multiple psychiatric providers. Now, this process is already cumbersome for a fully developed adult who has a firm grasp on their psychiatric needs, but for youth who struggle with suicidality, aggression, hyperactivity, family dysfunction, and trauma, which are my bread and butter, each switch is a major disruption to their course of treatment. In my written testimony, you're going to see examples of the challenges I've dealt with in my career thus far, so I'll spare you the repetition. You've also heard, or will hear from our panel of experts who are going to review important research that demonstrates the safety and benefits of offering psychologists a pathway to gain the expertise needed to prescribe psychiatric meds. And I trust that this committee is going to make a final decision that is rooted in the facts. The supporters of this bill and our opposition have some important arguments in common. We all care about the safety of our patients. I also believe that we are both sides are fully aware of the major shortage of psychiatric prescribers. For the sake of our patients, I hope that we will find a collaborative path forward because our youth simply cannot afford the status quo. Thank you for your time.
Four virtual witnesses on your panel, so we'll start with Sherry Goodman. If you can unmute and begin your testimony.
Oh, she just muted herself.
I think you just muted yourself. All right, there you go. Go ahead and start your testimony.
I'm sorry. Good afternoon, chairs and committee members. I'm Dr. Sherry Goldman, a pediatrician and a child and adolescent and adult psychiatrist in solo practice in Maryland since 1988. Practicing psychiatry. The reason I'm supporting this legislation is that access to psychiatrists is often difficult, as has already been pointed out. Many patients are put on wait lists which can be months before they're seen and evaluated. In my practice, I provide counseling and medication management together with a minimum visit lasting 30 minutes, not 10 minutes. I believe that medication without therapy is not sound medical practice. Medication can reduce or eliminate symptoms, but it doesn't help a person develop better coping skills. I realize that a lot of my psychiatric colleagues do not practice this way. They're content with providing medication and delegating counseling to others. But I feel it is far better if one well-trained provider, psychiatrist or psychologist or nurse practitioner, bring the full complement of mental health interventions to their patients. Many patients first seek help from a psychologist, and they understand psychopathology and neuroscience, so they already have a good foundation should they want continued training to be certified and licensed to prescribe medications. This would also give patients continuity of care, as mentioned before. Access to mental health is a problem in Maryland, especially in urban and rural areas. In 2025, there were approximately 4,500 licensed psychologists, approximately 1,800 psychiatrists, and only about 300 psychiatric NPs. The NPs can prescribe medication, but they're fewer in number. There are far more psychologists. And if some of those chose to get the advanced training and certifications so that they could prescribe psychotropic medication, access to this form of care would be substantially broadened. We need all kinds of mental health providers. Psychiatrists will not be replaced by psychologists who prescribe medication. In fact, having this allied discipline might free psychiatrists to address more complicated cases. For this reason, I hope you will support House Bill 1021. Thank you for letting me address you.
Thank you for your testimony. Morgan Sammons, do you want to go ahead and begin your testimony?
Thank you. Good afternoon. I'm Morgan Sammons, a psychologist and a retired Navy captain, urging a favorable report in behalf of HB 1021. Although I now live in Oregon, I was a resident of Maryland for over 20 years and was a longtime member of the Maryland Psychological Association, including a term as its president. During that time, I was in the first cohort of a program that existed in the Department of War to train psychologists to prescribe. I did so safely and effectively for almost 20 years, providing prescribing services to military members and their families in Maryland and throughout the world. In both metropolitan areas where I worked alongside my psychiatric colleagues, such as in the National Naval Medical Center in Bethesda, and in places where no mental health prescribers existed, such as in Iceland or combat outposts in Iraq, I was able to assist service members and their families with both psychological and pharmacological treatments. I prescribed a full range of psychotropic drugs to active duty members and their dependents. I treated diagnoses from depression to severe psychosis with a full range of drugs from agents for insomnia to lithium and powerful antipsychotic drugs. All psychotropic agents have some degree of risk. Several, including lithium, require close monitoring. As my training gave me the ability to interpret laboratory findings, I was able to administer these complex regimens safely. Maryland faces a shortage of qualified prescribers of psychotropic drugs. It has been demonstrated that in states where psychologists have been allowed to prescribe, as you will hear later from Dr. Hughes, they have been able to do so safely and effectively and alleviate partially this problem of shortages of appropriate mental health providers. Safety is an issue for all healthcare providers, no less so for psychologist prescribers. But the safety record of all non-physician healthcare specialties that have been given prescriptive authority is clear. Professions who add prescriptive authority to their scope of practice have uniformly done so safely and effectively. Allowing psychologists to prescribe will be to allow mental health providers with extensive training and experience to incorporate medication where indicated into treatment. Because psychologists are fundamentally trained in behavioral and psychological, not just medication interventions, they are best equipped to provide a complete range of mental health services to patients rather than simply medication management. The program I began in was an experiment in 1991, but with psychologist providers in 7 states, the Department of War, the Indian Health Service, and the U.S. Public Health Service, we are an accepted component of comprehensive mental health care who have a track record of proven efficacy in meeting rising demand for services. I respectfully urge the committee to provide a favorable report on HB 1021, and I'm happy to answer any questions you may have.
Thank you for your testimony. Kathy Seifert, if you want to go ahead and unmute and begin your testimony.
Thank you. So greetings to the chair and the committee. I'm happy to be here today, and I'm speaking in favor of House Bill 1021. I am Dr. Catherine Seifert, and I am a licensed psychologist in Maryland and past president of MPA. I work on the Eastern Shore with nurse practitioners, physicians, physician's assistants, and dietitians and other providers. We work collaborating with each other because we feel very strongly that that's the best service when you have multiple people in the same case, that we communicate in a very well and helpful way. We feel that very strongly that is a good way to go. I think psychologists who have prescriptive authority will also become part of that cooperative way of looking at a person, the whole person, and how we might work together to give the person better care. Additionally, 14 out of Maryland's 24 counties have health provider shortage areas. And so it's another way to look at where our shortages are and where we need to focus on where we need more providers and providers that have more skills. The rising cost of medical care means that we need to be sure that we are as efficient and as give care as well as we can, and that means we have to help the providers in mental health be able to provide as many services as they have proven that they are allowed, can do with care, and can do without any harm to their clients.
Can you wrap up your testimony, please?
Oh, sorry.
It's okay. I just wanted to make sure you could finish your thought.
Okay. So, I have seen and talked to people who are psychologists, as you just heard, that have very successfully provide psychological prescriptions for a long time and have done a very good job without any difficulty in having there be difficulty for the patient.
Thank you for your testimony. I have one more virtual witness, Philip Hughes, and then we'll open this panel up for questions. Philip Hughes, if you want to go ahead and unmute and give us your testimony.
Good afternoon, Chair and members of the committee. My name is Dr. Philip Hughes, and I'm an assistant professor in the School of Pharmacy and Pharmaceutical Sciences at Binghamton University. For the record, this testimony is my own and not that of my employer. I've submitted written research testimony, and I wanted to highlight a few of the key findings from that for you today. First, I'd like to talk about safety. I recently published a peer-reviewed study comparing the outcomes of over 21,000 patients who saw either a prescribing psychologist or a psychiatrist. This study used the same robust methods used by the FDA to generate real-world evidence for drug safety. Compared to patients treated by psychiatrists, prescribing psychologist patients had a 24% lower rate of adverse drug events, a 20% lower rate of using multiple psychotropic medications, and similar rates of emergency department visits and medication adherence. Prescribing psychologists appear to be at least as safe as psychiatrists. And I want to note that this data comes from states with competency requirements that are equivalent to those in the current bill and includes patients with a wide range of co-occurring medical conditions, signifying that they can treat those patients safely. Second, my research also suggests this bill is likely to increase access to mental health services. I led a policy simulation study that estimated how prescribing psychology might impact mental health prescriber shortages in every state in the US. And the results of that study suggest that this bill is likely to reduce the mental health prescriber shortage in Maryland by 8.8%. In additional studies, prescribing psychologists appear to treat underserved patients, including patients in rural counties and under-resourced communities. The research to date has clearly demonstrated that prescriptive authority for psychologists is safe and improves access to mental health care. Thank you, and I am happy to answer any questions you may have about the research in this area.
Thank you for your testimony. I'm going to go ahead and open up for questions. Delegate Hutchinson.
Thank you, Madam Chair. My question is for Dr. Goldman. And first of all, point of clarification, you are a medical doctor and you are a psychologist, right?
No,
I got that right. No. Psychiatrist. You are a psychiatrist.
Yes. I'm a medical doctor, trained in pediatrics, and did another residency in psychiatry and a fellowship in child and adolescent psychiatry.
Okay, so my question for you is I continue to hear that the drugs, the formulary that would be constricted under this bill, or at least I believe there is going to be a constriction on the drugs that can be prescribed, is the power of the drug, and that when you go through a psychopharmacology program, you're not trained on the whole body, and these drugs not only affect the brain, but they affect other organs, other areas there. And I'm happy to see you on a psychiatrist on this panel. Tell me what your thoughts about that, concerns, to refute any of that, all about the formulary and the power of the drugs.
As I understand the training that these individual psychologists, the advanced training for their master's degree would involve some schooling in physiology and pathophysiology of the whole body, not just the brain. I hope that would be part of the training anyway. It is true that everything we put in our body circulates, and there's a blood-brain barrier to prevent some things to go to our brain, but psychotropic medications are designed to go to the brain. I think it would be vital for them if they are treating, if they're using multiple medications or treating a medically compromised patient in some way, that they consult with the primary care physician or internist before prescribing. And then if there are any questions about how the body will respond to the medication, have adequate training to monitor and follow how the patient is doing, whether they're responding well or if they're not responding well. So I'm hoping that would be part of their training.
Thank you very much.
Delegate Hill.
Thank you, Madam Chair, and thank you for the bill. I'm pretty much going to follow up, I think, where Delegate Hutchinson was, because I've gone online and I see some courses like at the Chicago School, and I see courses that are completely online or largely online, and I don't see any restrictions in here. Is that right, Delegate, that there's no restriction in this bill, that it has to be a course that has in-person training with clinical components to it?
As the bill is written, I do not believe there are any sort of restrictions on how the additional training can be completed.
Okay, okay. And the reason I'm asking is, and also based on, I can't see doctor's name, the psychiatrist who just spoke, who said she hopes that it would include it. The Chicago School says the online MS clinical psychopharmacologic program at the Chicago School is a 2-year graduate degree program designed to educate you on medical conditions relevant to mental health care and psychological disorders, preparing you to integrate prescriptive authority into your client care services. So when I've spoken to psychiatrists knowing nothing about this bill, I'm talking over the last few years, they have issues with primary cares who understand the pathophysiology of the other medications, but not the significant psychotropic effects of the psychological or psychotropic medications they're prescribing. And it seems my concern is that the psychologists, at least as I'm reading, so I need you to clarify for me, are being trained about the psychotropic medications, and I've heard testimony saying they're great at the psychotropic, but they don't have the same breadth of experience, and I guess that's a question, to understand the rest. So maybe it's you, doctor. I don't remember your name, because you're a psychiatrist too, right?
Me?
Yes.
She's a psychologist.
A psychologist.
Dr. Smith.
Sorry,
Can
Dr.
someone
Smith
speak
might
to
speak to that.
where they get the training that allows them to not just do psychotropic, but to actually do the whole piece, which is what they're doing? And so, again, my psychiatrists are telling me all the time how they're picking up on thyroid
Hill, go ahead
medication
and let him
areas and
answer
stuff.
your
So that's
question,
really the
please.
question.
Sure, I'll be happy to try to answer your question. As a graduate of a MSCP program, the programs provide, as I stated, overviews of all the major body systems. In that regard, in the training, we are aware of the other impacts of the functions of the GI system, endocrine system, and the way the medications impact those systems and the way medical conditions may impact those medications, such as maybe drugs are impacting the liver, causing them to be inducers or inhibitors of other medications, other enzymes. The bills in every state, there's a coordination of care. So no prescribing psychologist works in isolation without consulting with or coordinating with a patient's medical provider. In this regard, the patient's whole health is covered. This is a specialty program that focuses on the psychiatric medication, but the prescribing psychologist works in concert with a patient's medical provider. So if there are medical concerns or medical conditions, then the prescribing psychologist would, of course, defer and have concurrence with the medical provider on their care. Does that answer your question?
May I follow up? Okay. Okay, thank you. It sort of does, but here's the thing. So as it is now, a psychologist without these additional authority, they consult with a psychiatrist who is both trained in the full somatic piece that the prescribing psychologist would connect with the primary care about, and they also have expertise in the psychotropic medication that the psychologist would have. So they're the one that has both pieces. And so instead, if I understand you correctly, are you saying that under this model, instead of consulting with a psychologist who has the full view, the prescribing psychologist would have part of the view and some experience with the other, and the primary care would have the other part and some experience, but there would be no one called into consult who actually has the global view of both pieces?
Any prescribing psychologist would be able to consult with anyone who would have the appropriate expertise in a patient's complex medical condition. The states that have this, I'm speaking from their laws, regulate that prescribing psychologists have to, by law, work with patients' medical providers to ensure that at a minimum there is coverage for safe prescribing of psychotropic medications and a patient's medical care is being covered. That does not mean that a prescribing psychologist cannot consult with another person in addition to that initial provider or a patient's primary medical provider. So there's nothing that says that if there was a complex patient, I could not work with that patient's current prescriber, psychiatrist, or their medical provider. I could consult with both and to try to address a patient's current mental health needs.
Thank you, Madam Chair. Thank you.
Delegate Taveri.
Thank you, Madam Chair. I see the value in this bill because as someone who has seen both, I can definitely see the value in this. However, I have also seen that maybe someone may not be as knowledgeable with the titrating piece of medication if they haven't been experienced to that. They'll know what the drug is for, but what about the practice of titration?
Sure. So the academic programs address this in terms of the clinical psychopharmacology coursework that focuses on both the medications, the side effects, the adverse effects, and the therapeutic doses. The common motto within prescribing psychology is to start low and go slow when it comes to titration. So prescribing psychologists in general are small c conservative prescribers. We tend to have multiple tools in our toolbox. So we try not to throw pills at any particular patient for all concerns. So the training does focus on titration, focuses on the administration, the metabolism, the distribution, the elimination of medications, and the factors that impact that.
So they would have to, can I just follow? So they would have to take additional coursework in order to?
The coursework's included within the domains I mentioned. The pharmacology, the clinical pharmacology, the psychopharmacology.
Okay, thank you.
Seeing no further questions, this does conclude this panel. We do have an unfavorable panel. Thank you all very much for your testimony. So we have Cynthia Lewis, and then online we have Molly Reese, Matthew Edelstein, Michael Young, Jacob Schwartz, Carol Vidal, and Teresa Miskimen Rivera. Cynthia Lewis, and then online we have Molly Reese. Can whoever is unmuted, go ahead and mute and also turn off the live stream. And Ms. Lewis, if you want to start your testimony.
Sure. Good afternoon, Chair, members of the committee. Thank you for the opportunity to testify today. My name is Dr. Cynthia Lewis. I am Director of Adult Psychiatric Emergency Services at the Johns Hopkins Hospital. I am co-chair of the Legislative Committee for the Maryland Psychiatric Society. I rise in respectful opposition to House Bill 1021, giving licensed psychologists prescriptive authority. The views today are my own and that of the Maryland Psychiatric Society. They are not representative of my employer. While psychologists play a vital and valued role in delivering mental health care, they do not attend medical school. Physicians complete 4 years of medical school, followed by 3 to 4 years of residency training, accumulating over 12 to 16,000 hours of supervised clinical experience managing complex medical conditions, pharmacology, and systemic disease. In contrast, the additional training proposed under this legislation represents only a fraction of that preparation and does not provide equivalent depth in physiology, pathology, or the management of medical complications. Psychotropic medications are powerful agents that affect cardiovascular, metabolic, neurologic, and endocrine systems. Safe prescribing requires the ability to diagnose and manage co-occurring medical conditions, interpret laboratory findings, and recognize drug interactions across organ systems. A limited postdoctoral prescribing certificate cannot substitute for comprehensive medical training. Additionally, this bill does not meaningfully improve access to care. Medicare currently does not reimburse psychologists for prescribing services, meaning many seniors would not benefit. Access challenges are more effectively addressed through proven strategies such as collaborative care models, where primary care physicians, psychiatrists, and psychologists work together, and through expanded telehealth services that connect patients to board-certified psychiatrists statewide. Maryland should prioritize strengthened, integrated, team-based care rather than creating a new, inadequately trained prescriber category. Expanding telepsychiatry, incentivizing physician recruitment, and supporting collaborative care will improve access without compromising patient safety. For these reasons, I respectfully urge the committee to vote unfavorably on this legislation. Thank you.
Thank you for your testimony. Molly Reese, if you want to go ahead and unmute and begin your testimony.
Hello, everyone. I'm Dr. Sandra Freyhofer, and I'm in for Molly Reese. I am speaking on behalf of the American Medical Association, and I'm a board-certified internal medicine physician. So I'm one of those primary care physicians we've been talking about earlier in this conversation. And as a primary care physician, I deeply value psychologists as essential partners in patient care. But I have to tell you, authorizing psychologists to prescribe medications is a high-risk, low-impact response to this mental health crisis we're all going through. Treating mental illness is complex, and understand that the psychotropic medications affect the whole body, and they can interact unpredictably. Many carry black box warnings, and managing these drugs safely requires a deep medical knowledge across all organ systems. Now, we're also concerned that this bill would allow psychologists to prescribe controlled substances and would open the door for them to prescribe to children, to the elderly, and vulnerable patients with complex medical needs. The proposed training outlined in this legislation is inadequate. 30 hours? Really? Psychologists don't have a medical background, and the curriculum endorsed by the bill is literally a crash course in prescribing. By contrast, physicians get extensive science and medical training in our undergraduate coursework, in medical school, and in residency. And by the time we go into practice, physicians have at least 30 times the number of clinical hours required by this bill. And we worry that psychologists will not be prepared to manage the complexities of psychotropic drugs. And finally, this bill will not meaningfully expand access to mental health care. Psychologists tend to practice in areas where physicians are already located, and that's true in Maryland and in other states who've enacted psychologist prescribing laws. And understand, psychologists are not rushing out to do this. In fact, only about 226 psychologists prescribe medications nationwide. So this bill would have minimal impact and would put patients at risk.
Thank you for your testimony. Matthew Edelston, if you want to go ahead and unmute and begin your testimony.
Yes, hello. Thank you so much. My name is Dr. Matt Edelstein. I'm a clinical psychologist, a member of the Board of Examiners of Psychologists in Maryland. I'm also a clinical psychologist at Kennedy Krieger Institute, where I direct a severe behavior program, though I'm not speaking on behalf of my employer today. On behalf of the board, I'd like to say that I appreciate the opportunity to testify regarding this bill, and I'm sure that the committee has received our letter of concern. I won't reiterate all of the components of the letter, but I will highlight the main points. Our chief concern is that the competency requirements of this bill are not outlined adequately, and in comparison to other states, seem to be lacking in specificity and are generally underwhelming. We are not philosophically against this bill, but about prescription privileges in general, but this bill does not seem to address the level of training needed in order for us to feel that we can safely manage, advise, and protect the public were psychologists to gain prescription privileges. Thank you so much, and I look forward to answering your questions.
Thank you for your testimony. Michael Young, if you want to go ahead and unmute and begin your testimony. Okay, let the record reflect Michael Young is not in the waiting room. Jacob Schwartz, go ahead and unmute and begin your testimony.
Hi, everyone. Chairwoman and Health Committee members, thank you so much for this important opportunity to speak out in opposition to HB 1021. My name is Jacob Schwartz. I'm a child and adolescent psychiatrist working in Montgomery County and also representing the Washington Psychiatric Society in partnership with the Maryland Psychiatric Society. We strongly oppose this bill seeking to give prescription authority for medications, again, that we've talked about with wide-ranging potential effects, not only on the brain, but to our lungs, heart, liver, muscles, and endocrine system. And you know, again, I've been struck by some of the discussion about the training. There is a big difference between learning this in books and in a classroom and seeing it when you're examining patients. We talked about our psychiatric nurse practitioner colleagues. They do 2 to 3 years of medical-based training and have experience with nursing and seeing patients. Just today, actually, somewhat fortuitous, there was a patient that came to me to see about depression, and I found clubbing on the fingernails, which is a very subtle sign, and it found out they were not depressed, they were having heart failure, and we immediately were able to get them to the emergency room and treat that. That is a very difficult thing to see from a book. So again, to highlight, we're talking a psychiatrist as a mental health professional who completes medical training with 2 years of intensive preclinical work, which is similar to the like what they're talking about here, where you're in classrooms, you're in books, as well as 2 years of intensive clinical rotations. We're talking about rotating with internal medicine doctors, surgeons, pediatricians, obstetricians, and gynecologists, and importantly, seeing patients. We then complete a 4-year residency, including over 6 months working with supervision as a hospitalist, as an internal medicine doctor, in neurology. These are years of seeing and treating illnesses, learning physical exams, laboratory results, as well as observation and clinical supervision. Again, our psychiatric nurse practitioner colleagues do 2 to 3 years of medical-based training and seeing patients. Our physician assistant partners, who still have to practice in agreements with physicians, do 2.5 years of medical education and up to 2,000 years of training in this part. Again, running low on time on that front. The other thing I just want to highlight is I appreciate Dr. Hughes and his research. I'm a little concerned by the very intense conclusions we've made from cross-sectional studies, and again, with only 200 prescribers. Thank you.
Thank you for your testimony. Cara Vidal, if you want to go ahead and unmute and begin your testimony.
Yes, thank you. Good afternoon, Chair, Vice Chair, and members of the Health Committee. I'm Dr. Carol Vidal, an adult and child and adolescent psychiatrist, associate professor at Johns Hopkins University School of Medicine. And I'm not speaking on behalf of my employer, but on behalf of MPS and WPS in opposition to this bill. You've heard my colleagues already talk about the vast differences in training between a psychologist who's a PhD and a psychiatrist who's a medical doctor. I would like to speak about the proponent's argument related to increased access to care. Psychiatrists are very aware of access issues, and we have solutions that are safe for patients. These include timely treatment, telemedicine, which has high patient satisfaction ratings and successfully brings mental health care to otherwise underserved areas. Incentives for professionals to practice in rural areas are also good, and most important, the use of collaborative care models, which integrate mental health and primary health care, extending the reach of psychiatrists by leveraging partnerships with other professionals in health, including primary care physicians, but sometimes even also psychologists who provide therapy. This is one of the best studied ways to improve access to mental health care, with over 90 randomized controlled trials demonstrating it's effective. Maryland is also a very privileged state. We have 2 training programs in Baltimore and 2 in DC, producing dozens of exceptionally well-trained psychiatrists yearly, many of whom stay locally. And additionally, as it has been mentioned, Medicare does not reimburse psychologists prescribing, which means that giving prescriptive rights to psychologists will not increase access for these patients. And while some rural areas of Maryland are indeed underserved, psychologists are not practicing in high-need rural areas. They tend to stay in urban areas once they gain prescriptive authority. Currently, as it has been said, there's around 200 psychologists licensed in the entire country. For that reason, the policy has little real-world impact on increasing access to care. In states where psychologists can prescribe, they generally choose to not prescribe. And I assume that's because they haven't been trained to do so. You have heard stories about 1 or 2 psychologists successfully prescribing, but you are legislating for everyone, and not everyone will be successful prescribing without medical training. So I oppose the bill. Thank you.
Thank you for your testimony. Teresa Miskimem Rivera, if you want to go ahead and unmute and begin your testimony.
Thank you so much, Madam Chair, Vice Chair, and members of the House Committee. Good afternoon. And my name is Teresa Miskimmen. I'm speaking on behalf of the American Psychiatric Association as the current president and as a board-certified psychiatrist. I can tell you that the majority of the speakers that came before me have provided strong testimony on some of the things that I'm going to bring up. We definitely strongly urge you and the members of the Health Committee to oppose the House Bill 1021. It will definitely jeopardize safety of patients with mental health and substance use disorders in the state of Maryland. Patient safety must be paramount when considering any change of law, and this bill definitely puts vulnerable patients at risk. Supporters of the bill propose that it could increase access to mental health care. However, there is no actual data to support the claim, including in rural and underserved areas for obvious reasons that have been stated previously as well. We do know, though, that in states that have allowed psychologists to prescribe, those states have not seen an increased access to mental health and substance use disorder services. Further, regardless of the misinformation we have heard prior panelists today, psychologists simply do not have the medical training required to comprehend the effects of psychotropic medications because it does not cover a full medical residency training. In contrast, psychiatrists such as myself, you've heard already how there's rigorous and extensive medical training. And because of this medical training is that we know that patients under our care with health-related comorbidities are at higher risk for potentially serious medication interactions. In summary, you must be medically trained to understand and treat all body systems beyond a psychopharmacology course. We strongly encourage the committee to protect patient safety by opposing HB 1021 and supporting proven evidence-based solution to expand psychiatric workforce. Specifically, we could definitely encourage you to expand the collaborative care model demonstration pilot and also telehealth and audio-only services as psychiatric workforce multipliers. I respectfully urge you to preserve patient safety, consider alternative solutions to any other prescribing privilege, oppose HB 1021. And thank you for your time and consideration.
Thank you for your testimony. I'm going to go ahead and open it up to the members for questions. Delegate Hutchinson.
Thank you, Madam Chair. I guess I'll start out with an observation because I've been looking forward to this bill. It's very important to everybody, and just surprised that there's only one sitting at the witness table and the rest didn't take the effort to come to Annapolis to testify here today. And I was going to ask this question to Michael Young, but I don't believe he is arrived on the panel. So I guess my choice is Mr. Edelstein from the Maryland Board of Psychologists. I represent the Eastern Shore, and on the Eastern Shore, my last count, we had 20 psychiatrists, 166 clinical psychologists who could be eligible to take a class in psychopharmacology and be eligible to prescribe. And it's somewhat of a personal situation because that happened to my daughter, where there's not a single psychiatrist on the Eastern Shore who takes insurance. But every clinical psychologist does take insurance, and there is an issue and a problem. I saw a crack in your testimony that there could be a compromise around the guardrails with this, but absent of that, then what's your solution? Because we do have a serious problem on the Eastern Shore, and how do we provide more access, particularly with pediatric patients, absent of this bill?
Thank you so much for your question. The crack in the testimony that you highlighted is that we are not philosophically opposed to this option, but as the other members of this panel have noted, the guardrails, the competency requirements are not well defined, and I think could be much more rigorous in order to do what our primary role is as a board of psychologists, which is to protect the public. If you were to compare the requirements across other states, and in particular the state of Illinois, there's 4 or 5 times more requirements for prescribing psychologists, including a significant residency requirement that would at least give that sort of clinical opportunity to rotate with different disciplines and learn about all of the systems. There's an undergraduate degree component. There's a lot of other pieces that would give us as the Board of Psychologists confidence that were someone to meet all of those requirements, they'd be able to demonstrate the skills necessary to be a safe prescriber. Absent of those things and some other things that are missing in this bill, including clear information about what coordination means with a licensed physician, other things such as not having sort of a pre-authorization period where that individual's work is supervised. It just feels very much like this bill was rushed, perhaps knowing the significance of the mental health crisis that you noted. But of course, as the other panelists suggested, fixing a problem is only as good as the sort of the least common denominator. And so we want to make sure that that we're making a safe choice to improve access for everyone.
Unfortunately, though, you didn't answer my question, and that was specifically with the issue that we have on the Eastern Shore. And when you have a psychiatrist that doesn't take insurance, that then leads to a health disparity to only those that can afford a psychiatrist. What other alternatives do we have outside of this bill to expand prescribing rights to the Eastern Shore?
I think that's an important question, unfortunately, and I see some other folks who want to answer it.
I'm fine if Dr. Schwartz wants to answer that question. That'd be great.
And correct, this is a complex question to answer, but our most successful has been collaborative care, which is kind of what people are referencing that they are assuming this would allow, which is basically through our primary care providers who do, quite frankly, the vast majority of our prescription. We're talking about for adolescents, they do the vast majority of our prescription of SSRIs, or antidepressant, anti-anxiety medications, as well as our ADHD medications. And basically, the collaborative care model is for patients that the primary care provider, the pediatrician, doesn't feel confident enough that they can handle on their own. They have mental health professionals, mental health social workers, again, colleagues that we talked about before, psychologists, and oftentimes a psychiatrist that they can then refer to. So for instance, they may have a telepsychiatrist that they can refer the more difficult cases to in things like for the Eastern Shore. But again, many randomized controlled studies, which is our gold standard, like collaborative care model is the answer. That is a much better answer than, again, a cross-sectional study that Dr. Hughes. Collaborative care, I think, is a much better model.
Okay, thank you, Madam Chair.
And you must have superpowers, Delegate Hutchinson, because apparently Michael Young has just entered the chat. So I'm going to open up the opportunity for Mr. Young to give his testimony before I continue with questions. So Mr. Young, if you would like to unmute and give us your testimony. Because apparently Michael Young has just entered the chat. So I'm going to open up. Mr. Young, if you can go ahead and turn off your live stream and begin your testimony. Thank you.
Oh, thank you, and sorry for the delay. I was in the waiting room after running down to the unit. It's a privilege to be here, and thank you for hearing us all out. So, and I have been able to listen to some of the testimony on my phone while I was waiting in the waiting room. So, really, I thought Dr. Schwartz really summarized it well in terms of the alternative mechanisms that we feel are very strong options for expanding health care access in terms of psychiatric prescribing to all Marylanders. It's a leading priority for us in terms of the Maryland Psychiatric Society to make sure that everybody has safe, effective prescribing. So telehealth expansion, collaborative care model, we feel like can really fit the bill on that and is a very effective and safe option. We think that physicians are in the best position to safely prescribe. You know, we know as practicing psychiatrists over the years the complexity of psychiatric prescribing. These medicines actually affect all systems of the body: the nervous system, respiratory system, cardiovascular system, endocrine, musculoskeletal, skin, urinary system, reproductive, immune system, digestive system. All aspects of the body. There's pharmacodynamics, pharmacokinetics involved, extensive training to just be able to tease out a clinical presentation and whether this is due to an underlying psychiatric condition versus a medical condition. It takes a very high level of medical training to do this safely, identifying side effects, identifying potential medical complications, and really knowing medicines from other aspects of medicine, other areas of medicine that could potentially interfere. So it's not just understanding the antidepressants, antipsychotics, mood stabilizers, but it's understanding blood pressure medications and other medicines for heart health and GI medications, and knowing through experience and clinical work what can interact with each other and what medicines can affect other medications, and really understanding side effects on that deeper level. So we feel so strongly about this. We love working with our psychology colleagues. I'm the medical director of the retreat at Shepherd Pratt. We have psychologists on the team, hugely valued by psychiatrists. They bring a dynamic component to the interdisciplinary treatment teams, and I have friends and colleagues that are psychologists that I value greatly. However, they excel in other roles, whereas the psychiatrists excel in that medical management role, as well as comprehensive diagnosis. So that's why we want to oppose psychologist prescribing and just for the safety of patients and the medical training required. Thank you.
Thank you for your testimony. Delegate Riley.
Thank you, Madam Chair. I would like to hear what the young lady, I can't read her name, I think it says APA, my eyes, I'm sorry. I know she had something to add, and I would love to hear that.
Thank you so much. And the first thing is that, yes, collaborative care, that's why I brought it up. Of note, in 2019, the state of Maryland actually proactively launched this demonstration pilot. And because of the success, it already has opened the required codes for Medicaid in the state. So that was a very important thing. And with collaborative care, everybody coming to the table has their role and responsibility, and it's an immediate psychiatric workforce multiplier. So I definitely echo what we have been hearing about collaborative care. I also, if I may, I wanted to bring up the issue with the education. Is that in order right now? Can I just, because there was some questions about that, can I do that?
That's fine. That would be great. Thank you.
Thank you.
Brief.
So what is typically not included in a master's in psychopharmacology is really and compared to medical school training, it's not replicated. It's not a residency medical training. It does not really include things like a human anatomy with a cadaver, dissections, comprehensive internal medicine courses, the extensive pathology, systems disease. It's a multi-year residency training. So it is the full body. I think I heard Dr. Young, Dr. Schwartz, and Dr. Vidal talk about this, and Dr. Freihofer, that it is intensive, it's rigorous, and there is a reason, because the body is the most complex and it includes, again, it's not only the psychopharmacology. You have to know. I heard somebody say that they picked up on clubbing. That's a very important aspect that could definitely lead to psychiatric sequelae as well. So I wanted to bring that in. The distinction really matters because we have to focus on whole body medicine. So I really appreciate that, letting me talk about that particular what's lacking in that.
Thank you very much.
Thank you.
Appreciate it.
Delegate Hill.
Thank you, Madam Chair. I would like to address the question to, and I don't remember your name, Doctor.
Dr. Lewis.
Thank you, Dr. Lewis. So I'm reading the American Psychological Association article from January 2nd, where they're talking about 3 levels of psychologists, and the first level being a non-prescribing psychologist, the second being those who have a master's degree but aren't prescribing, and then the final level is those who are actually prescribing, of which they say there are about 300 plus, whereas there are another 1,500 who hold the master's degree in psychopharmacology but are not prescribing. You've heard the testimony from, you've been here all day, and you've heard the questions. What do you have to add to help us understand that this is not a turf battle from your perspective? This has to do with, I think your testimony, patient care. So what do you have to add to the conversation?
Thank you for bringing that up, because you're right. I have been here all day, and we've heard a lot of kind of expanding the scope of practitioners because of access. And as a medical provider, someone who's been seeing patients for 25 years, I get really concerned that we're minimizing the impact of a concern about access, which we can address, but thinking that it's simply people signing forms or people taking a 2-year course and that then you're capable of doing all that we have been trained to do. As I was sitting here, I was thinking about even before medical school, and even before medical school in college, you have to be a pre-med major. You have to do the prerequisites. It's building on years of, and then you go to med school, then you go to residency, and every year is building on a foundation that allows you to then come and treat complex patients. I work in an emergency department. We are constantly worrying about, people think it's just symptoms. Symptoms can be caused by many things, many medical concerns. So the main thing is that patient safety cannot be compromised because of access. One thing I did want to bring up too is I was a National Health Service Corps recipient, which meant that I received monies and payback for loans to go to an underserved area. And I worked on the Eastern Shore. I worked in Centerville and Chestertown. And what I did is I gave 4 years, and this is still a program that is offered, to people. So I think what I would recommend is we look at all the access to care, which we do have, with telemedicine, with our psych NPs who've exploded in Maryland. I've trained them in the emergency department. They work alongside me. We have a lot of them, but we should incentivize people to go to the underserved areas. There are programs out there and monies. We should make people more aware of what we can do to increase the access. So the answer to your question is I really get concerned that we do have an access problem, but we have answers to it, and I worry that we're thinking that it's just very simple to expand the scope of other practitioners. And then I worry also that when I hear people looking for recommendations or referrals, they're looking for therapy. And I worry that if there's a lot of psychologists, and it sounds like there's not a lot, but if they start going the medication management route, who's going to be there to provide the therapy? So again, compromising safety for access when we can address access, that's my main concern.
Thank you. Thank you, Madam Chair.
Thank you. I'm going to make a comment before I ask my question. My question is going to be of Matthew Adelstein, so I hope you're still there. And first of all, I want to say thank you all for your testimony and for your appreciation of the work of this committee. The collaborative care model that extended, that terminated the pilot early and extended it statewide was my bill. The Behavioral Health Workforce Fund, which required a needs assessment, was also my bill. The telehealth was the speaker's bill, and Madam Vice Chair, but the behavioral health parity piece was my bill as well. But when we did the behavioral health workforce needs assessment, we identified that the need in Maryland, that we were at 50% of the need that we would have by 2030. At the time of the needs assessment, we had 1 pediatric psychiatrist on the whole of the Eastern Shore. I'm glad we have more. But I will point out that in order to access telehealth, you still have to have a psychiatrist that will accept you have to have a primary care provider that wants to adopt the model. So I will ask this question because, Mr. Edelstein, you said that you thought that this bill was rushed. But I am looking, and the bill has been in our system since February the 11th. And my understanding from the testimony of our sponsor is that she's been reaching out to the Board of Psychologists, trying to get feedback. And you came with concerns and feedback to a bill that has been available for public scrutiny for nearly a month. So what am I misunderstanding? I'm going to go back to the original question that Delegate Hutchinson asked, which is, if there are all these concerns about this bill, why are we just now hearing them? And if this isn't the solution to address our access to care, when we have done all of the things that have been articulated by the opposition, and we still continue to have a shortage, which we are going to have to address, because, again, I will say 50% by 2030, which is 4 years away. What is your solution? And why is the board not working with the sponsor on that solution?
Yes, thank you for that question. I believe that was directed to me. Is that correct?
That is correct.
Okay, thank you. Just for the record, it's Dr. Edelstein. I'm a clinical psychologist. So to my knowledge, when we received a copy of the bill, we were not asked to give input into the creation of the bill. We got access to the bill and debated it among ourselves. I think that there's two different pieces that I would highlight here. One is the access piece, which I agree with. And as a clinical psychologist, I find myself reaching out to psychiatrists all the time because they're an integral part of our work, and I wish there were more of them. So I'll say that. But as a member of the board, the first thing that I think about is, what would it mean to allow people to prescribe with the components that are specifically enumerated in this bill? Those components seem to us and to me to be inadequate. Specifically, 400 hours of clinical training outside of that master's degree. I think you heard our psychiatry colleagues quote thousands and thousands of hours of clinical experience that they get. 400 hours feels inadequate, and the number of patients that are enumerated in the bill are 100 patients, which to me seems inadequate to be able to then grant independent prescribing authority. There are other pieces like maintaining collaboration, which is not well defined. Again, we want prescribing psychologists, were that to be enacted, to be collaborating in a very clear way with primary care physicians, but that's not well established in the bill. In other states, there's provisional licensure that allows a higher degree of oversight initially to make sure that the prescribing psychologist is doing this well. That's not included in the bill. I mentioned residency. 14 months of clinical residency is included in other states' statutes, not included in this bill. So I think there is a way, and the board believes there's a way to do this well, to perhaps address some of the concerns that were articulated by some of my colleagues here. I don't believe that this bill does those things. And because our chief objective is to protect the public, we don't feel confident that a prescribing psychologist with these competency criteria will be well credentialed to do the job that, as my colleagues noted, it requires an extensive amount of training.
Thank you very much, Dr. Edelstein. As chair of the committee, I appreciate your commitment to working with the sponsor on addressing your concerns now that the Board of Psychologists has made themselves available to the sponsor. So are there any further questions for this panel? Seeing none, thank you very much for your testimony today. This does conclude the bill hearing on House Bill 1021 and our hearings for today. Did I miss someone? I saw you.
I was neutral on the last bill. My name's Alicia Clemens. My team called in to put me down for testifying on this specific bill.
On this.
I also have written testimony that's logged with you.
I don't have you on this bill. On this bill?
On 1021, yes.
On 1021. Okay, if you want to come and give your testimony, and just make sure that, that you share your information
Will do.
with our committee secretary.
I'm sorry to keep you all here an extra few minutes. It was important enough for me to actually show up in person, even though I live in West Virginia. I know our online people did not.
And you said you're neutral on this bill, correct? You said you're neutral on this bill?
Yes.
Okay, so I'm gonna let the unfavorable panel go, so you're not sitting in the hot seat for more testimony.
Yeah.
Okay, go ahead.
My name's Alicia Plemons. I'm the director of the Knee Regulatory Research Center and an assistant professor at West Virginia University. You've actually already heard about me today. The study related to suicide, that one was mine. Several of the other studies were also mine. And I think that this is an important enough thing that even though I have to pay for it myself to come down here, and I've never taken a single dollar from any professional association, I think it's important enough to drive down here to tell y'all at least about the research so that you have an unbiased look at what this looks like, right? So I run a giant team that we focus on this all day. And I have spent my 20s and quite a lot of my very now fleeting 30s focusing only on looking at quality and safety of healthcare providers under different licensing agreements. What you may not know is that when Utah was considering their bill, it was done by the Department of Commerce for over a year before it came to the floor. And I worked with them every step of the way to look at data. That's actually where some of these original suicide studies came from. I already ran the numbers since I was the one who did the studies and I have Maryland data. After 2 to 4 years in Maryland, the steady state would be 8 lives saved a year. By having access to different psychotropic medications 6 to 8 weeks earlier on average if we're looking at wait times in Maryland. One of the big questions that Utah had and Colorado, Hawaii and Washington, who are both considering these bills right now, and they asked me to look at, so I not only looked at it, I bought employment level data for every firm in the US from 1998 to today. They were wondering what happens to the psychiatrist. Are they going to go out of business? Are people not going to go to the psychiatrist anymore? So I looked at that. It turns out caseloads remain the same for psychiatrists. Not a single psychiatrist in the entire US lost their job because the prescribing psychologists came around. In fact, the new caseload for these prescribing psychologists were largely people who had not had access to mental health care previously. This may partially be because of insurance. This is also partially because, while I know many people have said today that they do not move to rural areas, that was the great part about buying the data for every firm in the US, is I was able to track where they went. And we saw that while, yes, many do locate in urban areas, between 6 and 8% of all the prescribing psychologists do end up going to rural areas where there is not an available psychiatrist within 35 miles or a 75-minute drive. So I just wanted to tell you all about the data today. Thank you for giving me a couple minutes. Thank you so much.
Thank you for making the effort, and I appreciate it. I think that this was actually very helpful for our edification. Are there questions for this witness, witness from the members? See, Delegate Hill, followed by Delegate Tavares.
So I appreciate the research. You said you came in neutral, not in favor. Was there any data that would give us pause that you came across that we should think about in any way?
So the one that has really made me think, and I currently have a PhD student that she's tackling this question as her dissertation, was related to malpractice rates. So we now have every bit of malpractice data from every prescribing and non-prescribing state in the US, and she's currently going through that. As of now, while we see that there are a few adverse action claims, it's not statistically significant. We find that it's actually at a lower rate than psychiatrists, but that's something I want more years of study. And every study I've talked about is peer-reviewed. I want that dissertation to be finished and peer-reviewed before I can say anything confidently about malpractice rates. So that is one part I'd have pause on.
Okay, thank you.
Delegate Tavares.
I'll just have a quick 2-part question. Basically, if you could share the data, and second, whatever you can. And second, if there is, what data do you have on addiction rates?
What was the second part of the question? I'm so sorry.
Addiction, substance abuse disorder.
So Much of this data is actually provided by AHRQ through different things that we have. Anyways, they restricted federal files because I have individual suicide records for people within the United States, and that's not something that needs to be made public. But I can give you every bit of data that the federal government has allowed me to release. And I'm happy to give you every bit of that, including all the ones that have been peer-reviewed and gone through this types of study. When it comes to substance use disorder, I didn't work much on this, except for when it came to pregnant women. So it turns out that being able to have psychologists involved in like de-prescribing, so tearing down some medications during pregnancy, we had lower rates of neonatal abstinence syndrome at birth, but that's the only real one that we've seen at this time. There's much more studies to do.
Seeing no further questions, thank you very much for your testimony. Thank you for letting me know. And if I can just ask you to meet with our committee secretaries so we can get your information. This does actually conclude the bill hearing on House Bill 1021, and it does conclude our bill hearings for today. Thank you very much.